because of excessive bleeding from the retroaortic renal vein. Thank you so much for listening.
Any questions for Dr. Tuck? The infection of prosthesis, synthetic prosthesis is a common problem. When it does occur, it's challenging sometimes as well now. We have the luxury sometimes of using something called arteriograft, which is a biological graft. Sometimes you can bypass that and to get people to get away with it. Sometimes you can use a subterraneous graft in the groin area, flap, and get away with it. But sometimes it's not possible to just get so ill, and long-term use of antibiotics may be necessary. The particular case, apparently a patient had very hostile abdomen, and the two surgeons who were there before were very concerned they couldn't do anything about the aortic bypass. They had to back out. So that's going to cause a host of problems for the patient. I would have done things a little differently. Unfortunately, the surgeon decided to transect the graft immediately and ended up having that amputation, which unfortunately made her problems worse. But you know, it is what it is. Unfortunately, we just have to know if it's possible to manage infected grafts and doing the things we can do to make them better. It could be very helpful. I'll thank you, Dr. Tao. I'm going to go ahead and get Dr. Cousins on quickly before we'll take a break. Dr. Cousins will be coming to us from Parkersburg, West Virginia. He's a consultant cardiothoracic surgeon with the WVU system, and he has worked in most of the WV hospital for several years, and is a very proficient cardiothoracic surgeon and very well liked by his patients. He's coming to us today on the topic beating heart coronary revascularization. Dr. Cousins.
Good morning. Can you hear me?
Yes, sir.
Yes. To Dr. Oye and the other conveners of this conference, thank you very much for this opportunity to present a topic that is near and dear to my heart, beating heart coronary revascularization, also known as off-pump CABG. We started this journey of beating heart surgery nearly 20 years ago now. Over the next few minutes, we would like to discuss issues of off-pump versus on-pump CABG and explain why we have chosen the off-pump platform for the management of isolated coronary artery disease. Now, as you know, cardiovascular disease remains the leading cause of death in the United States and most developed countries. The majority of the deaths are indeed due to coronary artery disease. Coronary artery bypass grafting, or CABG as it is known, is the most common heart surgery performed worldwide. And CABG can be traced back for more than 100 years. And of course, John Gibbons didn't come up with the cardiopulmonary bypass machine until the 1950s. So a lot of this work obviously was done with the beating heart prior to that time. Now, approximately 340,000 CABGs are performed each year in the United States. And just as a review, the picture here shows a picture of the heart and the coronaries. On the left, you see the heart itself. On the right, we've kind of dissolved the chambers of the heart, and it leaves the coronary vessels. And as you can see and know, the ascending aorta, or the aorta, is the largest blood vessel in the body. As the aorta root comes out of the heart, it gives a right coronary artery, which supplies the right side of the heart as well as the inferior aspect of the heart. On the other side, you have what's called the left main, and it's called the main because it gives the left anterior descending, which comes down the front of the heart and supplies the anterior wall as well as the septum, and the circumflex artery, which provides blood to the lateral wall and also parts of the inferior wall. And indeed, coronary artery disease is a result of diet, hypertension, diabetes, cholesterol abnormalities. All these things lead to coronary artery disease. And what happens is over time, plaque builds up, as you see here, in the artery and narrows the luminal diameter. This then diminishes oxygenated blood flow to the myocardium in that distribution, often causing ischemia, chest pain, and can lead to myocardial infarction, or what we call a heart attack. Now, these blockages are often made obvious during a stress test or just during a patient's routine activity. And typically, the gold standard remains coronary angiography, where we delineate the coronary arteries through a left heart catheterization. As you can see here, dye is injected in this picture into the left main, and you can see the LAD coming down the front of the heart, as well as the circumflex vessel going posteriorly. And then over here, you have the right coronary artery, as we discussed earlier. Now, if it is determined that the coronary artery disease cannot be treated medically or with PCI, or what's called percutaneous intervention, as in patients with left main disease, three vessel disease and diabetics, or people with low ejection fractions, then surgical revascularization is indicated. And the best way to one's heart remains a midline sternotomy. And contrary to popular belief, a midline sternotomy is very well tolerated from a pain perspective, as well as the incision readily heals in more than 99% of patients. And that's one of the patient's trepidations always that we have to help them with, is the concern that their chest is going to be opened. Oftentimes they get misinformation, and so we have to redirect and educate them that these incisions are very well tolerated. From a pain perspective, we typically give 30 pain pills, and I see patients back at 1 month. And most times in the population of 60, 70, 80-year-olds, the patients will comment, "Doc, I never took a pain pill since I left the hospital." Younger patients, a little bit different and require somewhat more pain meds because they still have a lot more muscle. The skin is tighter and they have a little more discomfort. But overall, the midline sternotomy is very well tolerated. Now, once we do a very controlled incision and open the sternum in the midline, we then open the pericardium, and then we have access to all aspects of the heart, as well as the ascending aorta and other vessels that are there. At this point, we then have an opportunity to make a decision as to which way we're going to perform the surgery. If we're going to use cardiopulmonary bypass, or so-called on-pump surgery, you see the pump posted there in the right-hand corner. We then first have to insert cannula into the ascending aorta and the right atrium. These cannula in the right atrium will drain venous blood returning to the heart into the pump, where it is filtered, oxygenated, heated, or cooled. And then the return is through the ascending aorta that gets the blood back to the systemic circulation, and the heart is kept virtually blood-free during that time. In addition to those two cannula, we also have to add a cardioplegia cannula into the ascending aorta in an effort to supply cardioplegia to stop the heart. And oftentimes we also do another right atrial cannula into the venous sinus, and so we can do retrograde cardioplegia through the coronary sinus. Those cannula cause quite a few issues periodically, however, and people can develop what's called post-perfusion syndrome, memory loss, or some refer to it as pump head. And very interesting story. Early on when we were getting into beating heart surgery, there was a lot of literature that was not favorable of doing the surgery with the beating heart. And a lot of cardiologists would not recommend their patients to us because of the literature. However, I had one cardiologist whose accountant needed bypass surgery, and he knew of the pump head and the memory loss. And he came to me and he says, "Jeff, can you do this patient with his heart beating? He's my accountant, and I do not want him to have pump head while he's working with my money." So he was a believer of the procedure, although he did not recommend it for most of his patients, but he wanted to make sure his accountant didn't have pump head. Additionally, stroke is a problem because once you place the cannulas in the ascending aorta, we still also have to place a cross clamp on the ascending aorta to deliver the cardioplegia to the heart. And people who have coronary artery disease also have atherosclerotic disease of the ascending aorta. And so oftentimes plaque can break off and go to the carotid arteries and cause stroke. Kidney failure is a problem for several reasons. One, the body is not receiving a pulsatile blood flow with the pump because the pump uses a roller pump, so it's very non-physiologic, and the kidneys often become deranged as a result of that. Lung failure is an issue because of the volume that we have to use to prime the pump. People oftentimes develop lung failure. Bleeding is an issue. We have to give a large dose of systemic heparin to keep the pump from clotting during the procedure, and oftentimes people develop bleeding. There's also a systemic inflammatory response that often develops because the blood is seeing non-endothelial surfaces such as the plastic coatings of the cannula that we have to use. And so for the most part, it's benign, but all of these type of issues become potential problems for patients when you put them on pump. So you can supplant that pump with these two devices here. This is a suction cup, which we use to place on the apex of the heart to help us with positioning. And then up here in the left-hand corner is a foot plate that's called a stabilizer that helps us to isolate the particular vessel that we're going to be working on. And we'll show you more about that in a moment. But off-pump or beating heart CABG is performed in approximately 8 to 15% of CABGs that are performed. It's much less invasive because we do not have to use the aortic or the right atrial cannulas. And because we're not using the pump or these cannulas, we use much less systemic heparin. And this in turn decreases blood loss as well as the need for transfusions. When you're not manipulating the aorta in particular, there's a decreased stroke rate. And because the heart continues to beat and the kidneys receive pulsatile blood flow, there is also decreased renal failure. Additionally, studies have shown that there is a reduction in post-op atrial fibrillation. And in my own practice, we have a post-op AFib rate of about 20%. Most of the literature for on-pump post rate of about 30%. And that's typically what I tell patients, that there's a post-operative risk of atrial fibrillation of about 30%, although most of it is limited to the perioperative period and people don't typically have long-standing atrial fibrillation after coronary artery bypass grafting. All of the things above cause us then to have a decreased length of stay. And as I'll show you in the data later, the majority of my patients are extubated in the operating room as soon as the surgery is over. And so they come out without any drips other than typically insulin and maybe Precedex for comfort. But this decreases the length of stay. And of course, the decreased length of stay represents a decreased cost for the patient as well as the health system. And also, most of the literature also supports off-pump CABG showing a better outcomes for high-risk patients and women. Now, in the on-pump surgery, women in particular have 2 times the morbidity and mortality of men. But when you do the surgery with the beating heart, women's morbidity and mortality equals that of men. As far as high-risk patients, those with the low ejection fraction, those with calcified aortas, renal disease, cerebral vascular disease, or bleeding disorders often do much better with the beating heart platform. And so here you see an open chest. The heart is being exposed. We have the suction cup on what's called the apex of the heart. And then we have the stabilizer, which helps to stabilize the area that we're going to be anastomosing. When you hone in on that, you can see the stabilizer here. This is in the middle. Here is the vessel that we're going to be doing an anastomosis on. We have placed a proximal tourniquet here to decrease the inflow of blood during this time. And we're using a small 11-blade scalpel here to do an anterior arteriotomy on the vessel for us to do our anastomosis. The other advance over the past years is also with saphenous vein graft harvesting. It used to be that we would just kind of fillet the leg open to access the saphenous vein. And particularly for diabetics, a below-the-knee incision of this type was often detrimental and non-healing. And so back in the day, we used to have what was called Uniboot clinics, where everybody who had had a lower extremity saphenectomy would come in to have their Uniboots changed in order to try to promote healing. Now we use an endoscopic vein harvesting technique for the greater saphenous and the radial artery. It's much less invasive with less pain, swelling, nerve damage, decreased infection, and these patients are rapidly mobilized after surgery. So instead of filleting the leg open, we use a very small incision, as you see here. The endoscopic vein harvesting system is then inserted, and then you can dissect the vessel superiorly and inferiorly using a little CO2 insufflation to make a tunnel. And then we get a very nice saphenous vein through removing through a stab incision for the proximal and distal, and then the remaining vessel is brought out through the incision that we had made there. Here you see we've already done the anastomosis on the heart, and you can see the vein graft being held here, and we have a partial clamp on the ascending aorta. And if you look closely, you can see how deforming this partial clamp is to the ascending aorta. And if this is a calcified aorta, this patient is at significant risk for atherosclerotic emboli and stroke. And so we've now supplanted that with what's called a heartstring. Here's an aortic punch, which makes a small 3.5 millimeter punch. We then have a delivery system that inserts this deployed what's called a heartstring. And this little cup, because of the pressure in the ascending aorta, sits up against the arteriotomy, and then we're able to sew around and do our anastomosis and subsequently pull this little area here, and it comes out as a string as we tie down our anastomosis. So this diminishes the need to put a partial clamp on the ascending aorta and cuts down on stroke significantly. So how have we done with this off-pump platform? Our current overall STS star rating is a 3-star. And this is based on the data that we have been able to generate from our off-pump data. And the Society of Thoracic Surgeons represents about 7,600 surgeons and allied health professionals worldwide. The star rating system is the most sophisticated and highly regarded overall measure of quality in healthcare, and it rates the benchmark outcomes of cardiothoracic surgery across the US and Canada. Only 6 to 10% of participants will receive a 3-star rating for isolated CABG surgery, and that rating places us here at Camden Clark Medical Center among the elite for CABG surgery in the United States and Canada. The star rating metrics have 4 domains: absence of mortality or morbidity, use of the internal mammary artery, and medications. And just looking at a little bit of our data here, anything to the left of the red dotted line is better than expected results, and all of our results, whether it's mortality, morbidity, IMA uses, or medications, are all better than what the STS expects. As far as ventilation, as I mentioned, most of our patients are extubated on the OR table, but here we have 3 outliers that had prolonged ventilation. As far as deep sternal wound infection, we mentioned earlier that the midline sternotomy is very well tolerated, and we've had 0 deep sternal wound infections. We had 2 patients with post-op renal failure, 1 with a post-operative stroke. We've had to have no surgical re-explorations. We use the internal mammary artery nearly 100% of the time. We've had no in-hospital mortality with our off-pump beating CABG surgery. We had a couple of patients with pneumonia. And as far as blood products, we've used no intraoperative blood products with this platform. Our total ICU hours you see here are down around 20 when compared to our like group are up at around 55. And so that's about 35 hours less with our off-pump. And so that decreases the ICU hours, costs, and patients' ability to mobilize and be discharged. And of course, we have a 100% cardiac rehab referral. So we believe that the off-pump platform is much better for isolated coronary surgery versus going on pump. We're able to eliminate a lot of the sequelae and bad issues that come with the pump. And we continue to promote this as the way to manage isolated coronary artery disease. We appreciate your attention, and we'll take any questions that you have. Thank you very much.
Thank you, Dr. Cousins. Excellent talk. Any questions? Yeah, Dr. Stenosis has a question for you.
Yes.
Excellent talk, Dr. Cousins. Congratulations on your excellent results. You may not remember, I actually visited you twice while you were in Charleston, West Virginia. My question is, here in Nigeria, we have a lot of very sick patients with low EFs, some come with completed infarcts. What EF would you feel comfortable? How low an EF would you feel comfortable going off on?
You know, we have had patients with an EF as low as 5% that have done quite well. We routinely do 10%, 20%. And if they don't improve to greater than 30 or 35%, we refer them before discharge. We usually put a life jacket on them We then have cardiology repeat an echo within 3 months, and if they have not improved better, then they get an automatic internal cardiac defibrillator or AICD. But our platform is very good, and those high-risk patients with low EF, we manage quite well. Sometimes we will use an intra-aortic balloon pump to assist us, but we typically manage them, and the majority of them do quite well.
Dr. Cousins, out of curiosity, what's the cost for the average person who is not on insurance that has to have the surgery?
Intentionally, I don't pay much attention to the costs because I don't want to have any bias. But we do have patients who have no insurance. Typically, the social worker works with them, and they're able to get some type of Medicaid or some type of supplement. And also, we've had some patients who didn't qualify for anything, and the university will often do compassionate surgery for those patients and make it very affordable, like reducing the cost as much as half. But I intentionally have always stayed away from, what the actual cost may be, as I don't even want to be subconsciously biased as to what I may do or not do for a patient because of their ability to pay or not.
Excellent, good talk. Yeah. Again, that's I agree with you 100% on that. Very well. Now, one more question before we let you go. What about how do you create an awareness for your off pump, for your beating heart technique? How do you create awareness to your community physicians to refer your patients for that particular surgery?
Yes, one thing that we do here locally is we have what's called Dinner with the Doc. And so we invite everybody of the age group that may potentially need coronary revascularization to dinner. I present our platform to them, have them giving them opportunity to answer questions or ask questions. And we do it that way with the open community. With the physicians, primary care physicians, as well as cardiology, we try to send out a brochure that talks about our platform and shows our STS data to make them aware of what we're doing and the success rate that we have.
Thank you. Thank you so much, Dr. Cousins. I appreciate your help. Thank you.
I appreciate you allowing me the opportunity to present.
Thank you. So at this point, we'll take a break, stretch your legs, get something to eat, and we'll catch up on the other side in about 10 minutes. So, thank you. Again, if you have any questions during the talk, please ask. We intentionally made the talk time at least 15 to 20 minutes to give us the opportunity to ask questions. Most conferences such as this in the US, you're only given 6 to 8 minutes to present your entire thought process. So 20 minutes is a lot of time. So let's ask the questions if we can. Okay. Is he ready? Peter Baik. Peter Baik, otherwise we'll go there. Okay. Okay. Okay, so we'll skip Dr. Baik and we'll go to Dr. Coussayer's talk. Dr. Koussayer and I actually trained at the Arizona Heart Institute many years ago. He is accomplished endovascular surgeon and proceeded to work in Florida for several years prior to moving over to Saudi Arabia, where he works at the King's Hospital Specialist Hospital. Dr. Koussayer has been a great member of our society, the EBDSS, and interventional specialist. Today, his talk will be on update on management of asymptomatic carotid stenosis 2022 SVS recommendations.
Good afternoon, Herbert. Yeah, just can I wasn't expecting, can you give me like just 3 minutes? I'll be ready.
Yes.
Okay, thanks. Hi, everyone. Can you hear me, Herbert?
Yes, thanks.
Share my slide. Let me see if I can share my screen. I share my screen.
There's a button beside the microphone with a square with an arrow going up. Once you click that, yeah, then it should prompt you to share your screen.
Can you see my screen now?
Not yet. Yes, yes.
I have to go back. Sorry. Go to the beginning. All right. You see my screen very well? Is my voice clear? Okay.
Yes.
And thank you again, Herbert, for putting this very nice meeting. Really, it's a great effort. And I wish I was with you guys, but hopefully next year I'll try really to be in person. I'm going to speak about a very controversial subject, which is management of asymptomatic carotid artery stenosis, because even until now, really, with all the guidelines, there's a lot of controversy about it. And we have a guideline just published a couple of months ago by SVS, and even the European Vascular Society, they published their own also guideline about 2 months ago, and they call it 2023. So I'm going to go all this through guideline and give you some, hopefully, guideline how we deal with this asymptomatic carotid artery stenosis. If you look at the nature history of asymptomatic carotid artery stenosis, an era of medical therapy, this is a very nice paper published in World of Neurosurgery in 2016. And they found the incidence of carotid stenosis prognosis in asymptomatic moderate carotid artery stenosis was high, even if use of aspirin and statin. So using aspirin and statin did not stop progression of the disease. And this is another paper also published in Journal of Vascular Surgery 2018. And they look at the 3,382 patients came to the hospital with a stroke, and they found 7% they already have asymptomatic carotid artery stenosis, more than 50%. And they came with a stroke, even they were on antiplatelets, statin, and some of them they were on both. So when they conclude that medical therapy alone is unlikely to be sufficient stroke prevention for patients with significant asymptomatic carotid artery stenosis. So if you look at the guideline from the Journal of Vascular Surgery, this one is a nice paper also published in 2020, and they look at correlation between asymptomatic carotid artery stenosis and the mobility and cognitive dysfunction and height fall in older people. And they found that asymptomatic carotid artery stenosis associated with impaired mobility and cognition that are accompanied with increased fall risk. And this impairment increased with the increased severity of ICS stenosis. So also can cause ICS stenosis, can cause impairment in the cognition, function, and mobility, and increase the fall, especially in old people. So if you look at the guidelines, it said we have two guidelines. We have a guideline come from the Europe, from the ESVS, it was 2017, and now they just updated a couple of months ago, they called it 2023. And then we have the new guideline from state, from the SVS, also published a couple of months ago by Dr. Ali Abu Rahma. If you look at the ESVS, even though the update one 2023, they did not change the recommendation from 2017 regarding asymptomatic carotid artery stenosis. So their recommendation, if you have stenosis 60 to 99% asymptomatic, they want you to look at three things. If the life expectancy more than 5 years and patient has femoral anatomy and he has more than one feature suggest high stroke risk on pacemaker medical therapy, then they want you to go and do a surgery or stent. If he doesn't have them, then you continue with the past medical therapy. So what are the features suggesting high risk stroke? This is the features they put it. If you have patient has any of these features and he has 69 or above asymptomatic carotid stenosis, they want you to do a surgery for this patient. This feature first, they are clinical, like if he came with a contralateral TIA or stroke. On cerebral imaging, if you see ipsilateral silent infarction in the area where he has a carotid stenosis. On ultrasound, if you see a stenosis progression more than 20% per year, because this double your risk of stroke. If you see a spontaneous embolization on transcranial Doppler, if he has an impaired cerebral vascular reserve, because you don't want to take a chance to lose more vascular brain bed, and large plaque, equiescent plaque, or increased juxtaluminal plaque or hypoechoic plaque, because this plaque are high risk for embolization. Or if you NMRA, you see intraplaque hemorrhage or lipid-rich necrotic core. So if you have any of these signs, they want you to go and do a surgery for asymptomatic carotid stenosis or stent. What about the Society of Vascular Surgery? Again, they just published their recommendation a couple of months ago. And they depend on the two major trials. We already know of that. And with the first trial, we know the ACAS study, asymptomatic carotid stenosis, is from the United States in 1995. And they have an update on this trial 2004. And the second large trial they depend on it is ACST. And they have also update one on called ACCST1. So let's go through all these two layers. The first trial is the ACAS trial, 1995. It's a prospective randomized trial. They have 39 sites, and they have 5 years follow-up. They have 1,662 patients, asymptomatic carotid stenosis more than 60%, and patients were on daily aspirin, and medical risk factor management for all patients. And they compare medical versus carotid endarterectomy. What they found, there is no difference in the total major stroke between both groups, but the incidence of any ipsilateral TIA or stroke or death was lower in the surgical group. So what they conclude that CAA reduced the risk of any stroke or death from 11 to 5% at 5 years in patients with asymptomatic carotid artery stenosis, more than 60%. This reduction about 53%. Also, the ACAS recommended CAA for patient aged less than 80 years as long as the expected combined stroke and mortality rate less than 33%. So for patient, you can do surgery, but your stroke, combined stroke and mortality should be less than 3%, because if your mortality and stroke combine more than 3%, you lose the benefit of the surgery. If you look at the ECST trial, this also they have 3,120 patients, more than 60% stenosis, and they have 5 years follow-up. And again, this trial showed an advantage in limiting stroke and death at 5 years for carotid endarterectomy with maximum medical therapy, and decreased from 10% versus 4% in the surgical group. And you can see here, they look at 5-year risk for all stroke in the CAA group was reduced by half compared with the CAA deferred group. That means the people on medical therapy. Also, as they look at 5 years risk for fatal or disabling stroke, and they found that the CAA group was reduced by half compared with the group who did not have surgery. Then we have a new follow-up on this study or trial. We call ACST1. Now you have 10 years follow-up, because ACST is only 5 years. This one 10 years follow-up. And even after 10 years, they notice that patients still get benefit from surgery. So CA for asymptomatic carotid stenosis younger than 75 years of age reduced 10 years stroke from 17 to 13.3%, was again about 4.6%, and half this reduction was in disabling or fatal stroke. So this trial showed even after 10 years, people still get benefit from surgery if they have an asymptomatic carotid artery stenosis. So some people will argue that about this trial, that this all the trials, and they don't use any statin, because statin is something new, and everyone say, oh, this all trial was they not use a statin, only an aspirin, and after we use a statin, we should not do any surgery for carotid asymptomatic carotid stenosis. But if you look at ACST1 trial that showed the stroke risk with the CA plus medical therapy was nearly half that on medical therapy alone, irrespective of patient having lipid lowering drug or not. So it does not make a difference when they look at the 10 years follow-up. Even the patient were on statin, they still get benefit from surgery. So look at that. So patient were on lipid lowering drug, they get annual stroke was 0.7% on CA group compared with 1.3 on medical group. And people who was not taking statin, also there was a benefit, drop from 3.3 to 1.8%. So statin really did not make a major changes. So people, even if you take statin, still surgery will give you a benefit for asymptomatic carotid artery stenosis. But best medical therapy may not be adequate for all patients. This is a very nice paper from Conrad, and he found that best medical therapy failed to prevent carotid stenosis progression in 40% of patients with carotid stenosis and development of ipsilateral neurological symptom in 12% with moderate 59%. So the second thing, why we talk about that? You see, not all carotid artery stenosis, asymptomatic carotid artery stenosis are the same. So you cannot just give a general, recommendation that everyone asymptomatic should we leave him alone, because all of them, they are not the same. And again, this is Conrad, he showed that if you just give a medical therapy, did not fail to prevent progression about 40% of the patient. And as I said, not all asymptomatic are the same because they have some of them, they have a risk factor we talk about, depend on the plaque and the morphology of the plaque. So you have to look at that. And the second thing is that not all asymptomatic patients are really asymptomatic, because patient may get a TIA where he's asleep, and when he wake up, he has no symptoms. So we think he is asymptomatic, but maybe he got a TIA where he's asleep. And the second thing we just mentioned when I start my lecture, that ACS, asymptomatic carotid artery stenosis, associated with a cognitive decline. And this is, it's very hard to measure it by looking on the patient. And there is also an evidence that cognitive function improve after CA or Cath, where is no improvement with the best medical therapy. What I talk about, give it the Society of Vascular Surgery to give their recommendation, give him grade 1B. This was a recommendation now in low surgical risk patient with asymptomatic carotid artery stenosis. More than 70%, they recommend CA with best medical therapy over maximum medical therapy alone for long-term prevention of stroke and death. This is very strong recommendation 1B. So, but you have to understand the factor to get the benefit, as you can see from the diagram here, the patient don't get benefit until after 2 years. So if patient life expectancy less than 2 years, he will not get benefit from surgery. So surgery is a long-term investment. So patient has to live at least 3 to 5 years. The reason why they say the life expectancy should be at least 5 years to see a benefit from the carotid surgery. The second thing, period of complications should be less than 3%. So if your stroke rate is high, then you lose the benefit from the surgery. The reason why it has to be done, if somebody has to do asymptomatic carotid artery stenosis, his stroke rate should be less than 2% or 1.5%. If your stroke rate is much than 2%, then I think you should not do surgery for asymptomatic carotid artery stenosis. Some people argue that male get better benefit than female, and this is not true. If you look at the ACST1 trial of 10 years data, and they found a similar benefit and no difference between male and female. Both will get benefit from the surgery. And this is also, then we have a nice also paper called an Oxford Vascular Study. Oxford Vascular Study also is a new one, is a prospective population-based cohort study and symptomatic review meta-analysis. They correlate between epicyclic stroke and degree of asymptomatic carotid artery stenosis, and they compare it with the best medical therapies. They have 2,354 patients, and they found that epicyclic stroke rate at 5 years for patient has stenosis 70 to 99% is 14.6%. If your stenosis is 50 to 70, then your stroke rate is almost 0%. So really, it showed very clearly that if your stenosis is more than 70, then your high chance of stroke. But less than 70, incidence of stroke is very low, and the reason why is they recommend only medical therapy for that. If you have more stenosis, 80 to 99%, then your really epicyclic stroke was significantly greater than people between 50 to 80. So the higher stenosis, the higher chance of stroke, and the higher recommendation to go and do surgery for this kind of patients. And you can see here all the diaphragm. So when they conclude that the stroke risk was high, depend on the degree of asymptomatic carotid artery stenosis, but the benefit of CA was cleared for patients with severe stenosis more than 70, and especially if it's 80 to 99% this range. But anything above 70 is really very clear that surgery gives you a benefit and decreased chance of stroke. If you're still in doubt, is everything I talk, if it's not convinced that you need to do a surgery, at least pick up this type of patient, because whatever I talk, it really tell you that you have to do surgery for all asymptomatic carotid stenosis more than 70%. But some people still argue, no, you have to look for risk factor and everything. So again, if he's not, you don't want to go with like clear, indication, then at least follow up this rule. So at least do surgery for this patient who are high risk for ischemic stroke. If the initial degree of carotid stenosis is more than 70, if you see a progression in the severity of asymptomatic carotid artery stenosis with the ultrasound, you do ultrasound every year, you see increased severity. This is a bad sign. It can twice the risk of stroke. If patient has asymptomatic embolization detected on the TCD, if patient has epicyclic silent embolic infarction on CTA or MRI, or if the carotid plaque morphology has risk figures like that. If you have ulceration more than 3 on the plaque, this increased risk of stroke about at 3 years. If you have a large black area, black ecolocity or intraplaque hemorrhage on MRI, all this sign of plaque, it's a bad plaque and better do a surgery for this kind of plaque. Or if you see reduced cerebral blood flow reserve. So at least if you don't want to do it for every patient, do it for this patient if they have stenosis more than 70%. What about stenting? Comparing with the stenting. If you look, and then we have an ACST2 trial. This one, they compare surgery with stenting, and they found that 3 days rate of death or any stroke was higher with the Cath comparing with the CEA. But there was not significant. And 5 years of procedure death or any fatal or disabling stroke was similar. So did not found any difference between both. But in 2017, we have meta-analysis of 5 trials. We have ACT1, CREST, EVA, 3S, ICS, and SAFIR compare CA with Cath in patients with asymptomatic carotid stenosis. And they found that perioperative stroke was higher for Cath compared with the CEA, and pre-procedure, but pre-procedure and ipsilateral stroke during long-term follow-up was similar, and the composite outcome of death, stroke, or MI similar. So if you put everything together, like MI, stroke, death, death, and MI, you see no different. But if you look only in the stroke, all these trials showed very clearly that you have higher chance of stroke with the Cath comparing with the CEA. Unfortunately, we don't have any randomized trial until now comparing Cath, either transfemoral or TCAR, with the best medical therapy alone. Sorry. This is a very nice also paper retrospective randomized study. They compared TCAR with the CA and the transfemoral Cath. And when they compared TCAR with the CA, they found no significant difference in the outcome. And they found TCAR set with a less degree of cranial nerve injury. But when you compare it with the transfemoral Cath, in patients more than older than 80 years, TCAR was associated with a 72% reduction in the stroke risk and 65% reduction in the risk of stroke and death. So when we do a Cath now, I mean, we follow up the recommendation. It has to be high medical risk, either severe coronary disease, severe pulmonary artery disease, end-stage renal disease, or uncontrolled diabetes, or a patient has high anatomical risk like contralateral ICA occlusion, radiation, distal ICA above C2, spinal immobility, tracheostomy, or contralateral laryngeal nerve paralysis. Patient has any of this risk, we prefer to do a Cath. Still, Cath is not our first choice for asymptomatic carotid artery stenosis. What about TCAR? TCAR, we like to do it if patient is contraindicated for transfemoral Cath, like he's old or he has disease arch, you know, very tortuous common iliac common carotid artery. So this kind of patient who are high risk for transfemoral Cath, we prefer to do a TCAR for them. So what patient unlikely to benefit from revascularization? If patient has severe morbidity due to other medical or surgical illness, increased perioperative risk, because as I said, if your perioperative risk more than 3%, you're going to lose this benefit. So if patient is very sick, very old, he has a lot of comorbidity, and your perioperative risk will be more than 3%, then don't do surgery for this patient. Life expectancy, if less than 2 years, because I said you have to wait for 2 years to see the benefit. So this will not benefit from surgery. If you have a prior disabling ipsilateral stroke, or patient with a total occlusion of the internal carotid artery, this group will not benefit from any surgery. So conclusions, patient with more than 70% asymptomatic carotid artery stenosis should be considered for CA, TCAR, or transfemoral Cath to decrease long-term risk of stroke. But again, patient has to be 3 to 5 years life expectancy. Perioperative stroke death rate should be less than 3%. Determination which technique based on the presence or absence of high-risk criteria for CA, TCAR, or transfemoral Cath, as I mentioned before. An upcoming randomized trial to answer rule of modern pharmacological therapy in management of asymptomatic carotid artery stenosis, and we're still waiting for the results from SPACE 2 and CREST 2. Thank you very much, guys, and hopefully I convinced you that patient needs to go to surgery if he has asymptomatic carotid artery stenosis. Thank you, Oye.
Thank you. Any questions from the audience before I ask my question? Doctor Samir, what would you do for a patient who has, say, 60% is symptomatic, and symptomatic, but the radiologist still feels that it's not high grade enough stenosis, radiologist speaking. But as a vascular surgeon, the person has disease. What would you do?
Patient is symptomatic. Usually, I review the CTA by myself. I don't go with the recommendation. I do my own measurement, and I depend a lot on the ultrasound, on the velocity. It's really velocity give you a lot of information, much better than CT angiogram. So if he has a high velocity, more than 250 or 300, I think I would treat him. I would do surgery. So I'm very aggressive with symptomatic patients.
What's your practice pattern now regarding CA and TCAR?
Really, we don't do much TCAR because you're a vascular surgeon, And really the only time I do a TCAR patient, he need a Cath for some reason, radiation to the neck, or he has tracheostomy, or and he has a very bad arch, type 3 arch. This is only the patient we do them. So it has to be really very strong indication to do a TCAR. Otherwise, we prefer to do a surgery or transfemoral. But if he has a disease arch or type 3 arch, I think TCAR become very handy. A very nice, easy procedure.
Yes. Very good. Thank you, Samir. Hopefully we'll see you in Nigeria next year.
Thank you, guys, and congratulations on the success of this symposium. Thank you, guys. Take care.
Thank you. Okay. So our next speaker would be Asad Akhter. We will be given a case presentation, and following him would be Yati Gupta. She'll also be presenting case presentation. Son.
Hey, doctor, how you doing?
Good.
All right, I'll just share my. Can you hear me properly?
Yes.
All right, and you can see my slides also too, right?
Son is presented from Canada. He's in Vancouver, Canada.
All right. Hey, good morning, everyone. Thank you, Dr. for letting me in presenting for the 5th endovascular solution for Africa. My topic is on ilio-femoral revascularization through brachial approach. I'm a third-year medical student from Avalon School of Medicine. Just a second, yeah. So let me just start off with defining what exactly is peripheral vascular disease. It's basically a systematic disorder that basically clogs up or develops plaques in your arteries and veins. And there are many risk factors for leading to peripheral vascular disease. It usually causes pain, discomfort in the affected limbs. If you look at the statistics, anyone who has PVD, they have a 60% chance of a coronary or cerebrovascular disease. Right? And a lot of patients are asymptomatic because of the higher risk factors. So let me run through some of the statistics as compared by CDC and WHO. So number one culprit you have is hypertension. So CDC defines anyone who has systolic more than 130, diastolic more than 80, or taking medication as someone who has hypertension. And you have 47% of people in the United States who have hypertension. And WHO puts about 1.28 billion people. Second culprit is high cholesterol. So anyone who has more than 200 milligrams per deciliter. About 38% of American adults have high cholesterol. Third one you have is the most common is smoking. We have about 31 million people in the United States who are smokers. And even if you are not a smoker, 1 in 4 people are still exposed to secondhand smoking. So you could still be at a risk factor from your family members who smoke and everything. And you're responsible for killing at least 7 million people every year. And the fourth one we have is type 2 diabetes mellitus, which CDC puts at about 37 million people who have type 2 diabetes mellitus. And so all of these risk factors, especially hypertension, smoking, and type 2 diabetes mellitus, hypertension and type 2 diabetes being the silent diseases, in the sense that as long they don't usually call, patients are not really symptomatic. You could have a patient who has a blood pressure of 200 by 180, and they could still be completely asymptomatic and won't be discovered unless surveillance is done by the primary care physicians. And so according to WHO, we have at least 230 million people in the world who have peripheral vascular disease, and about 9 million people, adults, who have that. So my topic is basically, when we perform endovascular procedures or surgery, we always prefer the femoral artery traditionally. And endovascular surgery is still in its infantile stage, because the reason femoral artery is preferred is because it has a larger diameter, lower complications. So there isn't much literature about going through do a brachial approach, but I found few research articles. So for example, in this paper, we they basically 2,226 surgeries were conducted by the vascular surgeons in Cleveland Clinic in Ohio, and 289 were through a brachial approach. Now, the reason why brachial approach is lower, it's only done when femoral approach cannot be done, right? But they found out in conclusion that the brachial approach has a higher success rate, right, in terms of reduced complications. And so some of the recommendation included that you make the cannulation 1 centimeter above the antecubital fossa, and you use a smaller sheath. So somewhere between 4 French sheath to 5 French sheath in order to prevent complications and everything. So out of 289 patients, you can see only 11% had pseudoaneurysm, 7% had thrombosis, and 3% had hematoma. And only in half of them, they required some kind of surgical intervention. So according to their statistics, they put their success rate at about 99.6%. And they also cited another group who put their success at about 99.5%. And they highly regard this source because they conducted 2,250 brachial artery procedures, but the only exception, they used the 4 French pigtail catheter instead of as a sheath. And the other interesting findings were, if they use aspirin or antiplatelet, it reduced complications of brachial artery stenosis to a significant level. But if they were on warfarin, it increased the complications. The second paper I found was brachial artery approach for repairing abdominal aortic aneurysm. So it's basically almost similar as to the previous article. They conducted 103 abdominal aortic procedures. 79 of them were done through brachial artery approach. And if only one individual had pseudoaneurysm, which resolved in 4 months. 7 had hematoma, which resolved only by putting proper compression. And 29 had extensive ecchymosis. And they came to the same conclusion that if you approach 1 centimeter above the antecubital fossa, use a smaller sheath, there'll be lower level of complications. And one thing that highlighted is that one of the common myths people basically have is that if you do a brachial artery approach, it can affect the carotid artery and the vertebral artery, resulting in blindness or vertebral basilar stroke. But in their report, they found that not that to be true. So most patients would prefer it because it gives you better cosmetic results, lower effects are basically seen, and most of the complications can be easily controlled on site if you do procedures through brachial approach. So my case study, we basically had a 52-year-old patient, and she's been patient of Dr. Oye since 2015. She had an amputation of the left knee. And since 2015, her PVD has been controlled with Pletal and warfarin. But during that time, she had a lot of procedures done on her lower limb, such as you can see on the left side. She had embolectomy, she had endarterectomy, femoral bypass, angioplasty. And so anyway, in December of 2021, she came to the office complaining of pain in her leg, specifically on her left leg where she had the amputation. And they can perform a CT angiography. So in CT angiography, you can see that the left, sure, she has pain in the left leg, but there's significant occlusion of the external iliac artery on the right side. And there's also a chronic occlusion of the superficial femoral artery on the right side. And so at that time, Dr. Oye consulted and told her that she needs to get surgery done, but she refused at that time. And unfortunately, on the 6th of January, she comes to the ER complaining of left pain, but she had severely increased right pain in her right leg. And so then it was decided that an surgical intervention is necessary in this case. So on the 8th of January, Dr. Oye conducted the surgery, and because she has an extensive surgical history of lower limb surgeries, a brachial approach was the only approach that was better in this situation. So we took an informed consent, injected 20 ml of lidocaine in the antecubital fossa, made a cannulation to access the left brachial artery using a microvenous needle through ultrasound, put in a microglide wire. And as you can see from previous research that recommended using a 4 French to 5 French sheath, especially in females to reduce complication, Dr. A used a 4 French and then a 5 French sheath. Next step, he inserted basically a 0.35-inch glide wire and exchanged it with a GR catheter and inserted a 7x60 milligram of Lutonix BOD balloon. And he performed, on the left side of the image, you can see he performed angioplasty just before the external iliac occlusion, and then also performed angioplasty just after the area of stenosis for 90 seconds at a 3-time interval. After that, he removed the wire, right? And then he went into the left side, and he also performed angioplasty on the left side, just in case, as the patient complained that there was also some area of stenosis there, and in order to help with her complication. And at this time, he recognized that there was no need for a stent. So we put the proline suture on, compression dressing. And on the 19th of January, 1 week later, she came to the office and she said that everything was okay. She didn't have too much pain in right leg, and the pain in her left leg was also okay. The second case study was a 68-year-old female, almost same. She had a right AKA, and she also had femoral bypass. She had long-standing PVD. She's been a patient since 2020, right? And when you perform a CTA, we could see extensive common femoral, basically stenosis, and also stenosis of the profunda artery on the left side. And so then we performed the surgery in the similar manner. We got an informed consent. We accessed the left brachial artery using a microvenous sheath and ultrasound. And we placed the 4 French sheath again. It's a female patient, and 4 French are better in order to decrease any kind of complications. And then we were able to put the wire basically through the left subclavian into the aorta, right, using a 0.035 glide wire. And then he performed angioplasty of the femoral of the femoral artery. And then he switched to a 0.18, a smaller guide wire, in order to go to the profunda and perform an angioplasty there. And on the left side, an iliac Y-band stent was basically placed just in order to keep the area open. Proline sutures were applied, and then benzoin and Colix were basically applied. And so here you can see, like, a lot of endovascular procedures are still, there's not a lot of literature on through brachial approach. And so I think these case studies and research articles prove that, it should be used as an access point with advanced technology in endovascular procedures. Thank you.
Thank you, Sam. Nice talk. Again, the benefit of brachial approach, and Dr. Denny, he was here earlier. He likes the radial approach. He does a lot of radial approach. I like the brachial. It gives me a little more ability to feel that the vessel is a little larger than the radial, but he likes the radial a lot. But it's a technique that with a hostile groin, the stomach can go from the left or right. And the left is easier if you're going to do the brachial, but you can still do it from the right. The presently treat them this way. They can leave the office without having to stay in the hospital 2, 3, 4 days like you'd expect. They can leave within 10, 20 minutes of the procedure. It's a big deal. Nowadays in the US, we can do procedures such as this in the office-based lab, OBLs. So we'll have Dr. Messner talk to us tomorrow about it. Okay, let's have the next speaker And she's ready. Next speaker, you ready?
Yes, I'm here. Hi.
Okay, our next
everybody.
speaker, thank you. Our next speaker is Yati Gupta. She's a third-year medical student also. I think this conference is not only for accomplished surgeons. We must train our younger doctors involved so they get that feel for what it feels to be physicians when they get there. So it's important that we get them early so they can be interested and hopefully come to cardiovascular surgery with the British Medical School. So that's the whole intent. So Dr. Gupta is going to talk about the rescue of failed AV fistula in the OBL. Yes, go ahead.
Yes. Sorry, just one sec. Good morning, good afternoon, everyone. I'm Yati Gupta, a medical student at Avalon University School of Medicine. And I'm here to talk to you about the rescue of failing AV fistula in OBL. Let me just put it to slideshow. All right, can you see my screen and everything and hear me?
Yes, good.
All right, I'd like to thank Dr. Oye for giving me the opportunity to participate in his conference and also the opportunity to be his student, where every day I was inspired by his office-based lab, which I'm standing in right now, where he did countless of amazing and inspiring procedures. So an OBL is an office-based lab where procedures are performed in an outpatient setting, and here procedures completed are arteriograms, venograms, aortograms, phlebectomies, shunt studies, AVF rescue, which I will be talking about two patient examples shortly, stenting, balloon angioplasty, and AVG repair. So AVF has so many benefits to it, which is one reason I was very inspired by it throughout my rotation. There's a decrease in financial burden, especially in underserved areas, due to the fact that these are outpatient procedures. So they're faced with a much less of a bill. Also, it's a faster recovery time due to the fact that these are, again, outpatient procedures. So within 15-20 minutes of the procedure being completed, these patients are able to go home, and as long as they, take care of the rescued area or whatever area they had the procedure on, and do the follow-up instructions accordingly, they should have a much faster recovery time. Additionally, there's improved efficiency of care, because right down from the complaint where the patient comes into the office to the imaging to the procedure itself is all done in one clinic. So there's less of the going between physicians, which sometimes, messages can get lost between. And also this can help increase access to care in underserved communities. If other offices had office-based labs where hospitals are not always available in the mile radius that people live in, then this can help them also get care that they may have to go to the hospital for, which were all the procedures I listed above. So I'm going to be talking about rescue of AV fistula. An AV fistula is the connection made between the artery and vein for dialysis access. It's used in patients with end-stage renal disease in order to receive dialysis. And basically the access is created and matures over 2 months. And while it's maturing, if the patient does require dialysis right away, a catheter would be placed for them to get their treatment. Basically, fistula maturation and its cannulation for dialysis would be decided by the nephrologist, who will see if it's large enough. And we know the rule of 6, which would be flow greater than 600 milliliters, greater than 6 millimeter diameter, less than 6 millimeters below the skin, and at least 6 centimeters for cannulation, and the thorough examination to be done within 6 weeks. So 500,000 people require hemodialysis in with about 100,000 new cases of end-stage renal disease yearly. So why are AV fistulas recommended as the ideal mode for dialysis? Well, first of all, it lasts longer compared to other types of access. It provides good blood flow for dialysis and less likely to get infected or cause blood clots. The 3 primary modes of access for hemodialysis include the AV fistula, AV graft, and the central venous catheter. But the AV fistula is correlated with the lowest mortality, morbidity, cost, and less complications like infections or blood clots. As we know, the central venous catheter needs to be flushed before and after use and is highly likely to get in. It is likely to get infected. So why would an AV fistula fail? So it would fail due to stenosis, clots, presence of accessory veins, or pseudoaneurysm due to repeated cannulation. And when it fails, it would manifest as a weak or absent thrill, high venous pressure during or before dialysis, excessive post-dialysis bleeding, or not enough blood sometimes if there's a stenosis, proximal swelling, redness, warmth, skin changes, or Steele syndrome. Steele syndrome is a hemodialysis access-related hand ischemia where there's hand numbness, pain, and coldness due to insufficient blood flow and perfusion to the area. So what are treatment options for a failed AVF? You can have medications, angioplasty with or without stenting, thrombectomy, surgical revision of failed AVF, or surgical creation of a new AV fistula. So just in this office, I'm standing here from 2019 to 2022, Dr. Oye completed a number of office-based lab cases, rescuing cephalic, basilic, axillary, and subclavian veins, and many more procedures. So it's a little overview here in West Virginia. So basically, the patients I'm going to talk about, they were referred from their hemodialysis centers following a malfunction to their fistula, and the malfunction was seen during or before their hemodialysis treatment. Basically, male and female patients ages 22 to 92 were seen in office, and venous ultrasounds, venograms, shunt studies were all performed to interrogate the AVF access. Venograms were performed in both the retrograde or the anterograde direction to help us identify any culprit lesions. And then as a result, angioplasty and or stenting of the target lesions were undertaken with appropriately sized compliant or semi-compliant or non-compliant balloons. So this is the first case. We have a patient, 75-year-old male, presented to the clinic for an AV fistula study. He was sent over by the dialysis center due to trouble getting access. He reported no pain. And here are his allergies, past medical history, meds, and past surgical history, which does show our brachial-basilic AV fistula placement. So here we can see the pre-op diagnosis, end-stage renal disease, and malfunction of the AV fistula, which we can see right around there. So the left basilic vein AV fistula in this procedure, which I'm about to discuss, had an angioplasty done with a 7x40 millimeter Dorado. So right here we can see in the imaging the tortuosity of the AVF or a kink, which is very large here and may eventually need a larger stent and angioplasty. So basically, this patient informed consent timeout was stated, and the patient was laying in supine. We put contrast mixed with normal saline to view the areas. We saw the axillary subclavian vein were patent, and we saw that four-segment of the V-shaped kinking in the proximal basilic vein. So as a result, we had to stent it because we didn't want the patient to have any further complications as, he already had trouble getting access. So a 0.035 inch guide wire was advanced, and we put a 7x40 millimeter balloon to the target area, the Dorado, and the angioplasty was performed, and 12 atmosphere of pressure was given for 3 minutes. So I'm going to show you the completion of the venogram, which did show improvement, but he will eventually need a larger stent, but at least everything was taken care of in office and he was able to get treated. So the area was closed with 5-O-proline benzoin 4x4 tape. So we're going to rest it now, but it avoided any further complications in the moment. So here we could see the kink, and then after deployment of the 7x40 millimeter Dorado, we see that it has improved. My next case is a AVF rescue of the cephalic vein, which this 74-year-old female was sent to our office from her dialysis center as she was unable to access flow from her cephalic AV fistula. She's been experiencing pain in the area. She described the area as a burning pain and rated it as a 7 out of 10. Also, she said that during her last few dialysis appointments, she was experiencing blood pressure drop and instances of clotting. So the patient currently has a permacath, which the dialysis center wanted to remove, but she does not want to remove it until her AV fistula is further evaluated. And again, here are her allergies, past medical history, medications, and surgical history. So here we can see in the picture, we have that malfunctioning AVF on the left arm, and we can see that there are competing branches around the vein. So here we're going to do a balloon angioplasty of the mid-cephalic vein with a 6 by 60 millimeter Cook balloon. And along with that, we're going to ligate these 3 prominent cephalic vein branches to help mature the AVF and get rid of any of the pressure gradient issues. So for this patient, again, informed consent was timeout stated, and the area was visualized with 50-50 contrast and saline, and of course we did lidocaine beforehand to numb the area, which is really cool to be able to numb it just in office to the area instead of putting them under anesthesia, having all of those risks that come with anesthetics, and to be able to just do it in office. So we saw the mid-cephalic vein had the area of web-like stenosis and the 3 prominent cephalic vein branches. So we incised it, 15 blade scalpel was used, and then these competing branches were captured and ligated with hemostats and tied with 4-0 silk. Then the completion venogram did show successful ligation of 3 branches. In addition, we also wanted to put a balloon in the area of the cephalic vein where there was some stenosis, and a guide wire was used to advance, and a 6 by 60 millimeter 18 LP balloon was put in the stenotic area. Following the procedure, a much stronger thrill was felt on palpation compared to the weak AVF pre-op. So we can see here the before picture where there's areas of the 3 competing branches, and then they were ligated, and with the balloon we can see flow has been adequately restored. And again, this just saved the patient a trip to the ER, to the hospital, to be admitted, which does improve their quality of life, treatment, access to care, financial burden, everything. So follow-up instructions for most AVF rescue procedures: you keep the area covered with 4x4 acrylics and ACE bandage for 24 hours. After 24 hours, dressing may be removed. Keep the insertion site dry and clean, and in 7 to 10 days, follow up for suture removal. So basically, end-stage renal disease and the need for hemodialysis is very dependent on a properly functioning AV fistula. When you recognize malfunction earlier, this can help allow us to figure out which appropriate rescue intervention can prevent thrombosis or anything that will require open surgery. Currently, 430,000 patients in the United States are dependent on hemodialysis. So this is a great way to have access to their care. Endovascular intervention can be easily performed in this OBL suite cath lab, so we can prevent more expensive operating room procedures, and patients are able to leave within 10 to 15 minutes post-procedure because only minimal sedation and local catheters are used. And it's so nice to see these patients feeling better and being able to walk out of the office themselves knowing they don't need to go through any more vigorous procedure. Thank you. Any questions?
Thank you, Dr. Gupta. That was a nice talk. Any questions from the audience? Yes, we have a question for you.
Thank you very much, Dr. Gupta, for that lecture.
Thank
my question is simple. What do you do to prevent clots that will lead to failing of an AVF? There's a vicious circle there, but when you have a failing AVF, it predisposes the patient to clots.
Sure.
Now,
yes.
from ab initio in creating one, how do you prevent it from failing through the formation of clots?
Well,
Essentially, the most AV fistulas, when you have problems, about 90% is from the venous anastomosis. So proximal end in this case. So in dialysis, nurse is able to tell you once they go to dialysis, do you have the high pressure? That's the first clue that something's going wrong. And if you have a good working dialysis unit and they tell you early on that they have problems, can begin to see clots, then that's when they need to come to you sooner so you can do a rescue. And that's one way to minimize the clot issues. Some patients, renal patients, have what we call dysfunctional platelet syndrome. So they tend to clot more than the average normal person who's not a renal patient. So you may want to consider an antiplatelet therapy. Obviously, when we listened up to Ahmed this morning, in Nigeria, people do well without it. Yeah. But in my patient population, people don't do well. If you don't put them, if you have someone who is predisposed to clot, you don't put them on Coumadin or Xarelto or something else, you're going to have a fully clotted graft. That will require you to go to surgery and either revise it completely or jump it, which is something else. So the benefit of the OBL is to ensure that we get to those patients long sooner. Because it's not easy to fix this. Stick a needle on wire, but shoot a shot, see what's going on, and then formulate a treatment. Could be as easy as a balloon, or could be more involved. So these patients may have a problem in the arm, but the issue is actually a more central problem in the chest. So when you shoot the venogram, you have to follow all the way to the chest. Because if you find a stenosis in the chest or occlusion sometimes, you just have to, if you're able to cross it, cross it. In that case, a balloon with a high power balloon, a balloon such as non-compliant balloon. I like to use the non-compliant balloon at that level. Sometimes you can get away without stenting using a non-compliant balloon. If you feel that there's significant recoil, then you may want to go ahead and put a stent. And the stents that I like to use, from BD, they work very well at that level. But yeah. Yes. Yeah. Okay.
Thank you.
thank you.
Thank you. This question, the OPL, like the grafts salvage procedure, but how much dye on average do you use? Dialysis patients.
Oh yeah, if they're already on dialysis, it's not much of an issue, of course. But if somebody who's early on has a fistula, not really on dialysis, I can really do one of those very minimal contrast. I would say I can do one of those that diluted contrast, 20 cc easily. Essentially figure out what the problem is, treat, and we're looking at. So you can tailor down. Again, when you do a non-renal patient who's already in dialysis, and they can give as much as one to go dialysis and clean up after that. Yes. Yeah. Any more questions?
Well, how would it be this set up OBL?
Well, you'll hear from Dr. Master tomorrow. He's coming to us from Texas. It's not, from my perspective, it's not a big deal. It's really easy to do, but some people go all the way. It could be $1 million venture if you want to go all the way, but we can talk about it. Yes. Okay, so we're going to go on to our next speaker. I'm not sure who's on the screen right now. Okay. Next speaker though is Dr. Baik, right? Sorry.
Baik.
Dr. Baik, Peter,
Yep.
Are you there? Okay.
Yeah, can you hear me?
Yeah, yes, Peter, we can. We have Dr. Peter Baik. He's cardiothoracic surgeon coming to, and he does a lot of cancer work. So he's going to talk to us today on an exciting topic. Peter, go ahead.
Yeah, thank you, Dr. Oy, and thank you for invitation. Can you guys see my screen?
Yes.
Okay, it's the presentation format, right? Just want to make sure. And then, so yeah, thank you again. And yeah, my name is Peter Baik. I'm a thoracic surgeon at Cancer Treatment Centers of America. And, you know, you may be wondering why are we talking about endovascular therapy in lung cancer? And so, but it's actually quite, you know, even though it's rare, it could be very useful. And we'll talk about why. So, so the objectives, we're going to do a case presentation and then discuss the types of vascular invasion by lung cancer, and then kind of discuss briefly, you know, when I only have 20 minutes. So discuss the treatment options. Okay. So disclosure-wise, I'm on the speaker bureau for AstraZeneca, and which is rare for pharmaceutical companies to sponsor surgeons, but lung cancer, it's actually very important. So case presentation, you know, this is a 64-year-old gentleman with who was diagnosed with small cell carcinoma in the left hilum, and you could see there's a mass here involving the truncus, or the first branch of the pulmonary artery. But he was found to have you know, metastatic disease to his bone, stage 4. And then he received cisplatin and etoposide and durvalumab until November 2021. And then he received radiation to lung and mediastinal nodes. And then he received durvalumab since until April 22. And so the reason why I'm presenting this case to start off is to show that small cell lung cancers, even 5 years ago, when you were told that you have stage 4 small cell, your 5-year survival, I mean, even 1-year survival is minimal at best. But now, the treatment has become so much better where people are actually living longer. And so what you're seeing is lung cancer becoming chronic disease. And with the non-small cell lung cancers, I mean, all the targeted therapies, the immunotherapies, I mean, it's just amazing how new therapies are coming out. And for you guys, for vascular surgeons, why is that important? Well, because it's becoming chronic disease, and now we're going to be seeing more and more of complications of these lung cancers. So here's another case presentation. 60-year-old male who was found to have a left upper lobe, 6.1 centimeter by 6.1 by 8.4 centimeter lung mass. And he was and that was done on low dose CT. And I know in Nigeria, you know, the smoking rate fortunately is not high, so that's always a good thing. But in the U.S., you know, still probably, you know, a lot of patients do smoke a lot, and so you know, he had the low dose CT scan done, and then PET scan show that the mass had SUV of 22.4, very FTG avid, and MRI brain didn't show any disease, and it was on transthoracic biopsy. He was found to have polydifferential carcinoma. Because of the mass and location, and you could see the nodal disease, they decided that he's gonna just need definitive chemoradiation, and so he ended up receiving carboplatin and paclitaxel with 60 gray of radiation to the left upper lobe, and the restaging CT showed that mass had decreased to 5.6 centimeters, so he actually responded quite well. When I was consulted for possible resection, and what you can see is that here's the mass, and this thing is right next to the arch of the aorta. And to me, whenever I see these kind of cases first, you know, I wish that they had referred this patient to me first, because then a lot of times it's much easier to resect. But of course, with radiation and chemotherapy, there's, you know, significant fibrosis. And so, you know, what are the possible ways of treating this? Well, he can't get any more radiation. And injury to the aortic arch could have been really devastating. But what I ended up doing was, because of what I did was did a mediastinoscopy to ensure that there were no mediastinal nodes, and then did a exploratory thoracoscopy to see if it's actually attached to the aorta. If the dissection was not going to be able to perform, then come back and tackle another day. But actually, I was able to, using just a thoracoscope, the adventitial layer came off actually really nicely, and it wasn't stuck at all. And so I ended up doing a left post-lateral thoracotomy and left upper lobectomy, and then final pathology showed that there was no viable tumor. Again, the therapy really worked well. And then station 8, however, outside of the radiation field, was positive, so he's receiving chemotherapy. So, staging wise, we know that, here's all the staging. And whenever we have chest wall, let me get to that. And, whenever we get to the chest wall, then it becomes T3. But if it's involving the great vessels, it becomes T4. When, even without nodal disease, becomes 3A in the newest AJCC 8th classification, and that's usually chemoradiation. But whenever you have these vessels, you got to talk to the thoracic surgeons, and even involving the vascular surgeons. So what are the types of vascular invasion by lung cancer? Well, the one that we always know, we see often, is the superior vena cava syndrome, and radiation oncology will say that this is a only emergence that they have to radiate. And then it's usually due to the external compression by enlarging mass or venous thrombosis from central catheters. For receiving chemotherapy, they have a lot of portocats and ports that, or even PICC lines that can cause venous thrombosis. Then the other ones that we see are pulmonary artery involvement. Here's the left main PA, circumferentially surrounded by tumor. And then aorta, like I said before in my case, it's usually seen with the adventitial involvement. Once it goes into the media and goes through deeper, it's bad news. And but most of the time, it's adventitial involvement. So how can we treat? And I'm concentrating on the thoracic, but you'll see a case later on in the abdomen that had metastasized. But what are the treatments? Well, SVC syndrome, like I said before, radiation oncologists will say that, hey, this is only one of the few emergencies that they have to treat right away. So it's traditionally treated with the radiation therapy in the U.S. Of course, chemotherapy, if it works great, but needs several cycles, several weeks. And, if this SVC syndrome occurs rapidly, they're going to have severe symptoms, including, swelling of the face, upper extremities. They could have redness. And so getting that treated fairly quickly is important. Surgical resection. Obviously, if there's a mass next to the SVC, you want to try to resect it, but that will require usually some kind of venoplasty or whatnot, because you're not going to just want to go in and take it out and peel it off, because then you're going to make the wall really thin. And so, and usually that's been done via thoracoscopy or thoracotomy, which is going to delay therapy. And then one thing that I learned is the availability of radiation therapy in Africa is very limited, West Africa, even in Nigeria. And so, trying to get the radiation therapy to be done to decrease the mass, to decrease the SVC syndrome, there has to be alternative. So before we get to the therapy, endovascular therapy, with radiation, what kind of damage can it cause if you receive it to the vessels? I mean, it causes reactive oxygen radicals, and then it causes significant inflammation. And here's a picture that here's a picture that I saw. And what you'll notice is that the vascular wall is really thickened, and there's a focal necrosis of the media. And this was actually on a coronary vessel after radiation, radiotherapy. That was on for Hodgkin's disease. And so with SVC syndrome, there was a paper by Dr. Ezike and his colleagues from Temple. And what they did was they had stented the SVC, and their restenosis rate was only about 11%, which is not actually bad at all for SVC syndrome. And the recurrence obviously was about 11%, and the patency rate ranged from 64 to 98%, and the complication was rate was about 7.5%, but the major complication was not high at all. And you would think that there would be a significant thrombosis, but there wasn't. And so, as you know, with SVC syndrome, this is a potentially another way of palliating the symptoms until the patient gets chemotherapy and radiation. Pulmonary vessels, hard to treat because we're trying to get to the pulmonary vessels by any type of catheterization is difficult. Not impossible, but you can do it, but it's not. And so doing any type of endovascular procedure, that in itself is going to be very difficult. And so then what you have to do is you have to do chemotherapy and radiation therapy. Surprisingly, if they respond well, the rate of having these vessels actually eroding and bleeding, I mean, it can cause bleeding from the tumors, but it's not usually from the pulmonary vessels. So aortic involvement, that's the one that, most interested. So here's my patient. And so what could we do if we have a patient that, for example, like I went in thoracoscopy, I cannot peel it off. What are the ways to treat this? Well, vascular surgeons, cardiothoracic surgeons, treat aortic dissections and aortic aneurysms with endovascular means using stents. And so in that principle, even if you injure the media, if you have a conduit that's protecting it, and you shouldn't have any major bleeding during this resection. So here's a paper by Dr. Argento, and what they did was they actually went in because without the endovascular therapy, what they had to do is when they were trying to resect the tumors was to put an endovascular graft, take the aorta of cardiopulmonary bypass and put a graft in. I mean, this is a major procedure, as you can see. And trying to do this for lung cancer that's invading, recovering from this, I mean, the patient's not going to be able to receive chemotherapy at all for a while until they recover. So there was a paper by Dr. Daniel. So what they did was endovascular stenting, then went in and resected it. And you could see in the picture what it looks like when they peeled it off the aorta. And here's one of the CTs that they had. They showed how it's a circumferential around the aorta. And so over 7 years, they actually did 9 patients. And there were no endograft complications, which is always a good thing. I mean, the alternative is major bleeding. And 8 out of those patients had R0 resection, which is something that you want to achieve as much as possible. And so this procedure, they did it using thoracotomy, but could this be done minimally invasive. But even using thoracotomy, patients should be able to receive chemotherapy within 4 weeks. So here's a case where there was a small cell carcinoma that had metastasized to the abdomen and circumferentially occluding the aorta, causing an aneurysm. And so the reason why I mentioned about even small cell cancers, patients are living longer, is that as patients are living longer, it becomes a chronic disease, then you're going to see these rare complications that you may have to treat. And with better treatments, you just have to kind of get them through that therapy, and potentially they may live even longer, whereas before the patients would have died. And so what they did was they, to the aortic unit graft, and so they were able to mitigate the aneurysmal dilatation, and patient can resume therapy. So I know that this is a topic that's very it's not done and often, and it is something that has to be very coordinated between vascular surgeons and cardiothoracic surgeons. Like myself, I'm a thoracic surgeon in the U.S. I don't do it's when we concentrate on lung cancer or malignancy or thoracic oncology, we tend not to do any type of cardiac or endovascular work. And so then there has to be a very good communication between the vascular surgeons, cardiac surgeons, and general thoracic surgeons, but to work in hand to kind of deal with the lung cancers now becoming chronic disease, and especially with the improved therapies of lung cancer. And endovascular treatment allows for palliation and definitely potential therapeutic benefits. And so, this is again, endovascular in lung cancer, you may question, but it's actually very important to know about and have it in our arsenal.
Thank you very much, Peter. Any questions for Dr. Baik? Any questions? Any questions? Okay. Very well, Peter. Thank you so much for the opportunity to hear you talk. I hope you stay warm in Chicago, and we'll see you next year in Chicago, I guess, right?
Yeah.
Okay. Thank you so much. Okay,
Appreciate it.
Thank you so much. Okay, our next speaker is ready. Will be Dr. Hager. Geoffrey, okay. Yeah. He's ready. Yeah.
Good morning.
Okay, our next speaker is Dr. Jeffrey Hager. He and I have a long history. When I was a lonely medical student, he was my chief resident. I'm interested in surgery, general surgery at that time, and I moved on to become a vascular surgeon like his. So I'm glad that Dr. Hager graciously has accepted in the heart of Lagos about venous disease and strategies for management of venous disease. Dr. Hager.
Hang on 1 second. Let me just make sure I get the video on.
No worries.
There you go. Is my image there?
Yes, sir.
All right, great. Dr. Oye, thank you very much for the invite. I thank the conference organizers also. I don't really know a lot about venous disease in Africa and in Nigeria. I did my best to understand it. And to be honest, I couldn't find a lot of data. So what I did is I just kind of did an overview of venous disease and the treatment options here in Europe and in the US. Feel free to torture me as you will as we go along. I feel the big issue with venous disease, as I got more involved with vein disease as a surgeon, you realize that it's very undertreated in the United States and in most countries. I think arterial disease is where we have really focused all of our energy. But as you focus more on understanding venous disease, it's amazing how poorly we've taken care of patients with chronic disease, not understanding vein disease. So I'm not talking about the little squiggly line on somebody's leg. I'm really talking about how tissue loss and non-healing wounds are, the majority of them are actually venous in nature and not so much arterial. Veins may not be sexy, but they definitely have a major impact on quality of life for many, many people. And I think awareness is a major item that we do here where I live. A lot of education of physicians, because our physicians still feel that basically if veins don't hurt, you don't need to treat them. But they really don't understand all the sequelae that veins do. And by the way, they rarely cause pain. Mostly they cause symptoms, and understanding those symptoms are pretty important. So in the US, over 30 million people a year suffer from venous disease. It's pretty common. So we have the bulging veins here on this image. That's classic varicose veins. All right. So basically that's a refluxing vein. In our country, the venous reflux is almost 10 times more common than peripheral vascular disease. If you look at the conference topics today, almost all of them are going to be focused on arterial disease. But I think I sound like the little kid in the corner, like, look at me. But venous disease is a major factor that we just don't pay enough attention to. So venous disease in general, so you all realize there's a series of check valves in your venous system. You know that these valves only really exist in your arms, legs, and gonadal veins. That's it. There's no valves in your neck veins. There's no valves in the central core of your body except for the gonadal veins. So when these valves, they allow the fluid to move up the leg, not backwards, then up through the next valve, not backwards. That's how it stair-steps its way against gravity. If these valves become incompetent, it basically allows backflow to occur. Well, backflow causes stagnation. So my analogy is if you think of a pump pushing fluid through a filter and then the fluid leaving that filter, if you were to kink the other end of that filter, you essentially would raise the venous pressure up or raise the exit pressure up. So if fluid can't leave that filter, even though you got a pump on the other side, you can't enter that filter. Well, that filter is your capillary bed. So basically the venous disease is taking away waste products back to the artery to be recirculated. If you don't remove that old blood, the new blood can't come into the system delivering nutrition and oxygen and head through that capillary bed very quickly to deliver the nutrition and remove waste products, boom, boom. If you back up that flow, if you have a higher vein pressure than normal, then it begins to be stagnant. And then it becomes ischemic, believe it or not, because you're not allowing new blood to come into the capillary bed as fast as it should. So chronic venous insufficiency is a broad term. It can definitely be from venous valvular disease, but there's a lot of other things that can cause high vein pressure. So just because you have a high venous pressure does not mean you have valvular disease. A duplex scan will easily show you whether your valves function or they don't function in someone's extremity, but you could have a clot, of course. Obesity, high central core pressures can slow venous return. Cardiac valvular disease, famous for this is tricuspid valvular disease, as well as aortic stenosis, congestive heart failure, pulmonary fibrosis. Remember, the right side of the heart is the venous return that goes to the lungs. Well, so if you have tricuspid regurg, pulmonic regurg, which is not very common, or you have pulmonary fibrosis, so what you're pumping into is resistance, that's going to elevate the venous side or the right side of the heart, which would cause edema. Kidney failure, these are all things that can cause swelling. I mean, the list can keep growing, but those things tend to cause venous insufficiency, meaning the fluid's not leaving the leg efficiently. Anybody that has swelling in their legs does not have good flow out of their legs. But my point is, it doesn't have to be valvular disease. So many doctors tell their patients, like, well, you have vein problems, that's why your legs swell. Well, there's testing you can do just to rule that out. So that's what we're going to talk a little bit about. So here are the basic SEEP categories that we use to categorize severity of venous disease. C stands for clinical, E stands for etiology, A is anatomical, and P is pathophysiology. We're really over here at C4, 5, and 6. 6 is an active ulcer. 5 is you've had an active ulcer, but it's healed. And 4 would be now you have the pigment, the hyperpigmentation, you've had the scarring in the skin, and you have swelling, dry scaling skin. SEEP4 is a candidate to develop SEEP6 fairly easily. This is the group that we would like to get to before we run into problems. So at SEEP3, when they begin to develop swelling, that's our target. Bilateral swelling, remember, and unilateral swelling are going to be two different etiologies usually. Bilateral swelling, usually you're going to look for a central etiology, what we just went through on the previous slides. Unilateral, though, tends to be anatomically different in that one leg, such as venous disease, a clot. Can be just that they have poor calf pump movement. They may have a foot drop and they can't move their calf muscle. That alone can cause swelling. So signs and symptoms, basically, you may or may not see varicose veins, but basically it's leg heaviness, achiness, fatigue. You can get restless legs with this, burning, itching of the skin. That's just because the skin is drying, because it's not getting proper nutrition, because it's not getting proper blood flow. Kind of back to we talked about the venous pressure ideas. Swelling, the derm changes, and then eventually ulcerations. Risk. So women are a little bit more common than men, maybe like a 60-40 women versus men in terms of it. A lot of men have venous disease. For a man to come into my office, they're almost always accompanied by their wife because they don't take care of themselves very well. So I know when a guy shows up, their wife has sent them to me, and usually they have pretty bad disease. Age, I have a lot of, I shouldn't say a lot. I have a subcategory of very athletic 18 to 20-year-olds, like Division I athletes that have significant venous disease. So you don't have to be overweight. You don't have to have a long-standing history of venous disease. The family history, the genetics is a major, major component for us. But we treat people in their 90s, we treat people in their teens based upon their symptoms, not just because they have a vein that we can see. They'd have to have some symptoms associated with it. Multiple pregnancies, prolonged standing, obesity, and of course, if there's prior injury to the venous system, they'd be at risk. So this is shows you what eczema-like changes of the skin are. This is diffuse scaling of the skin. They have little punctate ulcerations. This may not be from venous valvular disease. It could be from obesity. It could be from some other reason. They have central venous pressure elevation. Here's a ulcer. You can see the lower third of his calf region has a lot of dermafibrosis, a lot of scarring. When you touch that skin, it's like a cast around the skin. The skin cannot stretch because it's slowly been diseased over that long-term swelling. Kind of goes back, if we handled his swelling early, he wouldn't end up with this problem, but eventually that can ulcerate. The pigmentation loss here is from the previous ulceration. You can see the ulcer is healed. Here's another picture of ulcerations. So realize that 70 to 90% of chronic leg ulcers are related to venous disease, not arterial disease. And here's the last picture. But this is all the advanced skin changes: a hyperpigmentation, dermafibrosis, dry scaling skin. So this would be like the end stage smoker. We don't want to see this patient. We want to see them before this, because this is where a lot of them end up. So in general, like when we see the patient, you're going to ask about their past medical history and general health overall. But I want to know their symptoms. Oftentimes, they don't understand the symptoms of venous disease. So really, I'm looking for leg inequality, swelling, dry scaling skin, areas of pigmentation. Usually it's along the medial calf region and ankle region. That tends to be a high zone of venous pressure. So on exam, usually they have arterial pulses and this overall swelling. So our best test by far is venous duplex. So a venous duplex for this is done in a standing position. It's not a standard DVT test. DVT test would normally done in a supine position. This a patient stands, and basically you scan it from the groin serially, and you will scan their deep system, and then you'll scan their superficial system to include the greater saphenous vein, the small saphenous vein, and any obvious incompetent perforators, which connect the superficial system through the muscle into the deep system. So in this image, you'll see all the way to your left, you'll see an augmentation. So the patient's calf is relaxed, the probe is over the vein, and then you basically just give a little squeeze to the calf, and that augments. That would mimic a calf pump movement in like when you're walking. So it shoots the blood out of the leg, and then the blood will fall backwards. If your valves work, you won't see all this continued flow. It'll just stop very quickly, less than half a second. This is about 6, how many seconds? This is 6.3 seconds of reflux. So as you squeeze, then 6.3 seconds, it's continuing to go back into the muscle bed. And that's showing that that's reflux. That's congesting the muscle bed. So just to kind of go through arterial disease and venous disease, arterial disease is kind of very easy to understand. We're opening up things to get blood somewhere. Venous disease, we're closing things so blood will stop going somewhere. We're stopping that backflow down the leg. So you'll see the little image to the left, that's normal venous flow. This is how normal valves function. Blood goes up, can't go back through that one-way valve, goes up to the next valve, can't go back through that valve. That's the normal flow out of the leg. When the valves are no longer competent, meaning the vein is dilated a bit and the valve's usually not damaged, it's that the vein is kind of dilated a bit. And as it dilates and pulls that valve apart, that allows gravity to go down to the next valve. Well, the next valve is going to have more pressure on it because of that distance. You just went a little bit further, so a little more pressure, and it makes the next valve kind of dilate, and down the road it goes. Our goal is to find out where these valves are not working and fix those segments. So simple things we'll use to start with. Exercise, of course, we want everybody to exercise. I don't feel exercise is going to change vein disease, but it may. Stagnant activity is the worst. So standing still and sitting still, basically you're not using your calf pump in your legs, stagnates vein disease. So if you're going to sit, I'd rather your feet up. If you're going to stand, I'd rather you move. So that calf pump is extremely effective, as you saw on that duplex scan, at moving fluid out of your leg. Elevation is great. I mean, nobody has neck veins dilated because we stand. Elevation, if you put your feet up, it takes the vein pressure off because gravity is removed. If you put anybody's leg up that has venous disease, you'll see their veins completely disappear. You put a little tourniquet on their legs and you have them stand, you won't see any dilated veins. But you don't need valves to work until you stand. So gravity is our enemy. Compression therapy is super effective. So compression therapy basically will augment that venous return so it can't congest in the capillary bed in the calf. So compression therapy is a big stumbling point for a lot of patients. So finding a stocking that fits the patient properly, educating them on how to put the stocking on and how to take them off. Like when we see patients in our office, my medical assistant goes in and spends about 15 minutes with them, putting the stocking on them, taking the stocking off, showing them the tricks of the trade, because if they don't wear them, they don't work. So a little extra effort will make a big difference in their compliance. And not everybody's 100% compliant, but I make them come back about 2 weeks later so we can talk about what was the problem, why couldn't you wear these stockings? And then I try to problem solve where we need to go and try to still get them on board, because compression therapy is very effective. You know, if you don't have venous valvular disease and you have kidney disease or tricuspid valvular disease, your answer is compression. So we need to get them compliant with compression. I think when I was a young vascular surgeon, we just give them the script for stockings and say, see you later. But I think over time, I've realized that my job is to get them compliant, because it will improve their long-term outcomes and their quality of life. So I think when you show some interest in their care, they'll realize the importance of it and they try to comply. Unsual therapy, it's a zinc oxide wrapped gauze, followed by compression therapy. Usually goes from the forefoot to just below the knee, and that augments venous return or stops venous congestion. That's the standard for how we heal ulcers. Stopping the venous congestion is very important, and that tends to heal most leg ulcers. So in terms of therapy, therapy has changed a lot. I was raised with ligation and stripping. I did not like ligation and stripping. I always considered it a trash basket surgery, because we didn't really understand what we're doing, why we're doing it. We didn't duplex patients 30 years ago. We just kind of guessed where their problem was, and we went and fixed it and pulled out the veins, and Well, you know what? Probably like 30–40%, we probably did the wrong procedure because we never evaluated. So that duplex scan, we'll talk about these other technologies that involve catheters and they sound sexy, but really what's changed venous disease is that we do that preoperative duplex scan so we know where the valves are not working. It's like an arteriogram before you do intervention on a blood vessel. You need that arteriogram preoperatively, or a CTA or whatever technology you want to use, but you need that preoperatively to plan your intervention so that it's effective and safe. Venous disease is the same way, except we just use ultrasound. Ultrasound is amazingly dynamic and accurate in terms of telling us what is actually going on inside the blood vessel. So the ultrasound has helped define the effectiveness of venous surgery. The last time I did a ligation stripping on a patient is probably 15 years ago. So current technology allows you not to have to strip, although current technology mimics stripping. So stripping is removing the greater saphenous vein from the saphenofemoral junction down, usually to the ankle region. Well, in reality, most valves from the knee to the ankle do function fine, so they do not need to be removed. Secondly, when you strip the section from the knee to the ankle, the saphenous nerve is very close in proximity there. I'm sure you've seen post cabbage harvest. You can easily get nerve damage there where you get hypersensitivity. Hopefully you don't and you just get numbness. But pulling the vein out with a device, a stripper, increased risk of nerve injury significantly, and chances are you didn't even need that segment removed. So now with endovenous techniques, we only seal the segment that has disease. If we need to save that lower calf vein for future bypass, it's there for them. So the main technologies now are thermal, chemical, are the most common. So thermal, it's radiofrequency or laser ablation. Basically, they provide heat to the lumen of the wall, and that by that, they essentially weld that vein closed. Chemical ablation is basically sclerotherapy. So you have a couple of FDA-approved drugs in the United States for these chemical ablations. I'm not a fan of chemical ablation alone. I believe that risk of that traveling out of the vein is higher than is reported in the literature. So usually we recommend, even if it's a very tortuous greater saphenous vein, we'll do a very short radiofrequency plug at the saphenofemoral junction. These catheters do not navigate tortuosity well at all. So you just plug it at the top and then you can put your chemical behind it. Or you can clean up with a chemical as needed for the residual varicosities. The glue that's out there that we have now is a cyanoacrylate, basically super glue. That's been used in arterial procedures, especially brain aneurysms, for quite some time. Basically, you put, all these are catheter delivered devices. So you would put it into the greater saphenous vein, you slowly release it, and as you release it, you put extrinsic compression on it, and that forms a immediate crystal bond to close the vein. What we're seeing with this technology is there's a fair amount of allergic reactions. So it's not in my armament. It's a nice feature because you don't have to do tumescence. Tumescence is when you put the catheter into the greater saphenous vein, we essentially put fluid around the outside of that vein then. That does three things. It basically evacuates blood from the vein because the vein will just squeeze right down, so it has close proximity. So when the laser or the radiofrequency catheter fires, it has universal wall apposition. And lastly, it's a heat sink, so it radiates any heat, so there's no thermal damage beyond the venous wall itself. When you use the glue, the cyanoacrylate, you don't have to place the tumescence. Tumescence is painful to patients as it distends the skin. It kind of feels a bit like an Indian burn. Patients tolerate it really well. We do all our surgeries awake. We give them a little oral Valium, like 10 milligrams. Doesn't knock them out, but it makes them not so anxious, which helps them significantly with these procedures. So I feel that general anesthesia is overkill for these patients. You just have to be patient. You have to be willing to talk to your patient and keep them calm, but they do very well with just the local. So here's the current recommendations. So now, again, we're talking about higher level venous disease. We're not just talking about a varicose vein that's not symptomatic. So the question is, how effective and how aggressive should we be once a patient has a leg ulcer? So actually, I'm having a little trouble reading it. If you have a suspected leg ulcer or one that's about to occur, there's definitely data say get after it, find where the reflux is, fix it. It's 1B criteria category that the data supports being aggressive. The question is, once you have an ulcer, does it help heal it faster? So the data is 2C for that. It's suggested that it may, but there's no strong studies that say it heals faster. The way we do this in our practice is we try to heal ulcers conventionally. I will give them probably about 6 weeks to, of course, in that time frame, you want to see improvement throughout that time frame. If they're improving, we'll let them actually heal, and then we tend to do their ablative procedure if they have venous valvular disease. But we don't jump right away to get the venous hypertension under control, because there's no data to say it makes it heal faster. We have had some patients that are just recalcitrant to conservative management. Those patients, we do go on and ablate, and it definitely speeds those patients up. But run-of-the-mill ulcer that's actually healing with Unibut compression, whatever your technologies are, we tend to wait for them to heal, and then we go ahead and do the closures. In terms of prevention of future ulcers, there's strong data that it should help prevent future ulcers. It makes sense. If you heal an ulcer in somebody's leg and then you don't fix the reason they got the ulcer, they're going to get another ulcer. So if they have venous valvular disease and that's the etiology for their ulcer, obviously fixing that venous valvular disease is going to be the best thing you can do to prevent that. If you do not do anything, 100% chance you get another venous leg ulcer. And doing something could just be wearing compression. But if you don't do anything to change their environment, so to speak, 100% recurrence. If you can find venous reflux and you can treat it, recurrence rates are approximately 30%. So this is just basically how the device works. So the device goes into the vein. Tumescence goes around the outside of the vein in the middle picture. That compresses the vein so it has wall apposition with the catheter. And then the catheter is fired, and essentially it welds the vein shut. The longer the segment, the better the closure rates. Closure rates overall are about 98%. The 5-year data for disease-free symptoms is about 95%, with most technologies except for the sclerosant. The sclerosant, which is the chemical irritant, it's about 80%. That's why sclerosants are low on when we use them. We use them after ablation, like this endovenous ablation, because I think it's a complementary procedure. So patients are, again, usually done in the office awake. They're up and moving right away. We have them do a walking program. We have them walk 15 minutes per hour the day of and the day after. They can resume regular activity, wearing compression, thigh-high compression, right away. We just ask them not to do anything strenuous or repetitive, like prolonged walking, prolonged bike riding. I don't want them lifting anything where they have to hold their breath for several weeks. They wear compression for about 10 days. We see them back 3 to 4 days later, check an ultrasound, make sure there's no DVT. The risk of DVT from this procedure is approximately 0.1%. In good hands. Your rate should not be much higher than that. So 99.9, you should be DVT free. There are heat-induced thrombosis. They call them HITs, HIT 1, 2, and 3. And that's about the basically propagation off the end of the catheter into the saphenofemoral junction, into the common femoral vein. Depending upon the progression of that clot into the vein is how the categories run. Almost always these resolve within about 10 days once you put them on anticoagulation, Eliquis, Xarelto, etc. They revolve very quickly with anticoagulation therapy. Open surgical procedures are extremely rare. Again, it's been about 15 years since we've performed an open surgical procedure, even microphlebectomy. So let's say we have this picture here and we've closed this vein. this should be the result in about 3 months. The vein doesn't just immediately disappear. It's like a balloon that's been inflated for a couple days. You untie it, it does shrink down, but if you actually give it some more time, it shrinks down lower. So it's about 80% of our patients will have this result without further intervention. 20% of the time, the vein may just still have a little backflow, maybe from a perforator we can't identify. Those we'll do a phlebectomy on. Phlebectomy should be like a 2 to 3 millimeter incision. We do it under local, so 1% lidocaine over this whole area. Little serial stab wounds, and then we have like a, looks like a crochet hook device. We just pick up the corner of the vein and just kind of pull them out. Patients are awake for this. We still give them a little bit of Valium, but a little local. It's amazing if you're just gentle what you can do for a patient. We have them come back the next morning because they will have a little bit of bleeding from those sites. We usually just use steri strips, no stitches for these, unless it's a giant vein and it requires a little bigger incision. But patients tolerate this very well. They go home taking Tylenol, or Motrin. The endovenous procedures, we just have them take Tylenol. No anti-inflammatories. Anti-inflammatories tend to recannulate these closures because, if you think about it, you're using heat to create inflammation. Using an anti-inflammatory may not be the best thinking. We did see early, when we did lasers like 20 years ago, we did see some early recannulation that we felt were secondary to anti-inflammatories. So arnica is a very mild anti-inflammatory. It's a herbal medicine that we use. That works, as well as Tylenol, a bag of ice. That's it for pain control post-operatively. So overall, these procedures are very safe. Obviously, if there's thrombus, we don't put catheters in those patients. We'll wait for the thrombus to resolve. If they have a thrombophlebitis and that propagated into the greater saphenous vein, I basically wait until that resolves. That's probably the main contraindication, as well as DVT. All right, Herb?
Thank you, Jeff. Appreciate it. Thank you so much. Any questions from the audience? Any questions?
Yes, that's an observation.
Sure. Okay.
Thank you for the presentation. We see lots of chronic vein diseases here. When you talked about the ulcers that follow from venous insufficiency, and that there is no link, there's no strong evidence to showing that the ulcers will heal when you correct the insufficiency, or maybe the reflux defect. I kind of like just, I wasn't quite comfortable with that, in that I've always known that the venous insufficiency leads, just like you mentioned, it leads to nutritional, as peripheral distant nutritional deficiency, peripheral deficiency in the skin, perfusion, nutrient deficiency, and then the skin. So if you deal with that, you should heal the ulcer. So I'm just kind of.
Did you get that, Jeff?
Yeah, I don't disagree with you at all. I think you're correct. This is just the latest. This data is old. You can see it's 2014. I don't know if your slide moved back for you or not. It's 2014 data, and what it's just saying is that the data is weak to say that it speeds up healing. It definitely has a major effect on recurrence. So I think that data is not correct, because we do see patients healing faster when we're more aggressive with it. But I'm just trying to give you what our society guidelines are at this point. I think you're correct, though, 100%.
Thank you, sir.
Thank
You're
you,
welcome.
Jeff.
Thank you.
Thank you. Jeff, you still there? You still there, Jeff?
Yes. Yes.
Okay, hold on a second. There's a question from, there's a question, let me see, there's a question for you.
I started controversy, huh?
Yeah. There's a nurse from Bayelsa, southern part of Nigeria, who wants us to know what's the relationship between multiple pregnancy and varicose veins.
That's a good question. I don't know if we exactly know the reason for it, but you can assume, I assume, one, it's the recurrent intra-abdominal mass, let's say, right, from the pregnancy. Two is, there's a fair amount of hormonal changes that allow laxity in ligaments in the pelvis to, allow for delivery. Could they affect the structure, the smooth muscle structure of the vein wall? I would say yes. So we see basically patients with their first pregnancy, if they've gotten a varicose vein, it almost always resolves once they deliver. So that's where I think there's a strong hormonal play on the venous smooth muscle. But by the time they get to their third child, the veins tend to not resolve. So I think the repetitiveness of that hormonal challenge, as well as potentially a mass effect in the abdomen, contributes to it. And the fact that those veins almost always resolve after the first pregnancy suggests that it's more hormonal to me.
Jeff, along those lines, what's your take on dyspareunia associated with venous insufficiency?
Say that again, Herb.
Dyspareunia associated with venous insufficiency.
Ah, so that's actually a whole lecture in itself. So there's a fair amount of gonadal reflux that is very underdiagnosed. And you see a lot of dyspareunia, you see a lot of pelvic pain, perineal pain, you see it in labial varicosity. So I oftentimes see varicosities that extend below the inguinal ligament, so they're in the upper thigh. But when I scan them, it's not from the saphenofemoral junction or from any venous structure in the leg. That means it's gonadal. We recently just did a pretty successful triathlon athlete, male, who is having all sorts of venous or pain in his groin region. Basically, that's reflux for a male as a varicocele, but they were spilling over into his upper thigh. So the only valve structure in the pelvis is the gonadal veins. They can have reflux in them. When they reflux, you get all this nesting of venous structures out of the ovary or testicle, and they tend to spill around the labial region and down into the leg. So ablation, we use coils for those. It's actually a fun topic. It's a lot to discuss, but we have a pretty good practice with this, and it really helps a lot of people. But you got to put the effort into understanding the pathology of it.
Thank you, Jeff. Appreciate it. Yes, that's it. Thank you, and hope to see you in Lagos next year for the 6th annual celebration. All right, thank you.
Thank you.
All right. All right, so we'll move right along. Next speaker comes to us from Berkeley, West Virginia. She is Dr. Chinenye Ezike. She is diatrist, foot and ankle surgeon, and she works at the Royal General Hospital in Berkeley. She is aggressive with wound care and ulcerations, and I'm pleased to introduce her to our audience here.
Okay. Hello, everybody. Like Dr. Oye said, my name is Dr. Ezike. I'm the podiatric foot and ankle surgeon here in Raleigh General Hospital, Berkeley, West Virginia. It's a pleasure and an honor to be in your midst. And my topic today will be diabetic foot ulcerations. Let's see if this. Okay, can everybody hear me?
Yes.
Awesome. So with respect to diabetic foot ulceration, this is a very expensive disease process to manage. Here in the United States, it accounts for about $200 billion spent yearly to manage diabetes and the related complications. And pertinent to diabetic foot ulcerations, an approximate amount of $9 to $13 billion US dollars has been utilized to manage diabetic foot ulcerations. Now, one of the most common complications of diabetes in lower extremity is the ulcerations that happen, and approximately 15% of diabetic patients will develop diabetic foot ulcers in their lifetime. And diabetes is the leading cause of non-traumatic amputations, accounting for approximately 60% of these forms of amputation. And this is according to the CDC It also shows that between 2007 and 2017, the cost of diabetes has risen up to 60%. So what are the risk factors? Foot ulcers are it's the single most common precursor to lower extremity amputations, and the risk factors are outlined here, from PVD to peripheral neuropathy, structural deformities in the foot, history of ulceration, and vision loss. And the risks for ulcerations can be categorized based on whether it's general or systemic contributions, or issues localized to the foot. So with general contributions, examples will be like uncontrolled hypoglycemia, how long you've had diabetes, vascular disease, blindness or vision loss, chronic renal disease, and older age. And local issues specific to the foot is peripheral neuropathy, structural deformities, trauma, from improperly fitted shoes, callus development, and history of prior ulcerations. But specifically, peripheral neuropathy in the face of unperceived trauma is the main key factor leading to wound developments in diabetic patients. So this is a nice schematic diagram just showing the various pathologic process that culminates in to diabetic foot ulcerations and eventually amputations. So in the branch of neuropathy, these patients often have a combination of motor neuropathy, sensory neuropathy, and autonomic neuropathy. So with motor neuropathy, there's often an intrinsic loss of muscle function, so muscle wasting in the intrinsic muscle groups in the foot, and also muscle atrophy in the anterior compartment of the lower extremity, leading to weakness. And then the spared muscles that were not affected by the motor neuropathy, they gain mechanical advantage and cause structural deformities such as hammer toe deformity, equinus contracture, or pes cavus or flat foot deformity. The problem with this structural deformities is that it starts causing abnormal weight or pressure transfer to focal areas in the foot, and that will eventually lead to callus development, breakdown, and that's how you get an ulcer. So in the branch of sensory neuropathy, there's the loss of protective sensation. So they're not able to perceive like light touch, or if they step on something small and sharp, they might not recognize it and adequately treat it. There's also the loss of proprioception. So they're not aware of where they are in space, which leads to balance problems. And then with autonomic neuropathy, there's inadequate innervation of the sweat glands and sebaceous glands, leading to dry skin, fissures, and a higher propensity for skin breakdown. So you combine this neuropathy with vascular disease, microvascular, and trauma, it's easy for them to have, diabetic foot ulcerations and eventually amputations. I'm going to touch on some of these components in a second. So one of the main problems I face in the wound care center when treating my diabetic patients is impaired wound healing. And the problem is most of these wounds are just stuck in this chronic inflammatory state. And it has been attributed to excessive levels of matrix metalloproteases. What these enzymes do is to digest collagen within the wound, and collagen is a very important building block to wound healing. And in addition to the excessive MMPs, they also have a low level of growth factors, which is essential for healing wounds. Then in addition to that, there's a problem with vasculature. So they have like generalized atherosclerotic disease and microangiopathy. And this is primarily due to a larger level or higher levels of age products, that's advanced glycation end products. And this has been directly linked to increase in capillary basement membrane. And this will decrease how much oxygen and micronutrients can perfuse the skin. So abnormal biomechanics, the most common I find are hammer toe deformities. That's when the toes are contracted and creating pressure points, whether on the top of the toes, the tip of the toes. Equinus contracture, which is limited range of motion of the ankle and dorsiflexion, which causes increase of forefoot pressures, and then flexion, extension, contractures, which is essentially like hammer toe deformities. So the main culprit with abnormal biomechanics, aside from motor neuropathy, is this age products. What it is it's a reaction of glucose or sugar derivatives with proteins or lipids. And in patients with diabetes, especially if your A1C is over 7%, histologic studies are finding high levels of this age products deposited in tendon structures. And when there are high levels of age products in structures, it causes stiffness. So this is just explaining what equinus contracture is. So essentially with equinus contracture, you don't have as much range of motion to dorsiflex the foot up. So which means there's a propensity for your foot to be somewhat in a plantar flex position because your Achilles tendon for the most part is tight. And in diabetic patients, because of the high levels of age products, they have stiffness in the Achilles tendon, which keeps their foot in a somewhat plantar flex position. And that causes increased forefoot loading. So here you can see there's, ulcerations here in the forefoot, and you can kind of see that their forefoot is quite prominent. And this is because of the plantar flexury position from the equinus contracture. Is that for me? Okay. So I'm just going to go over some cases that I've handled in the wound care center. So I had a 77-year-old male patient with diabetes polyneuropathy. He had a history of recurrent ulceration on the bottom of his left foot. No precipitating trauma. He's a non-smoker. Physical exam, he had palpable dorsalis pedis and posterior tibial arteries, but he had no sensation to light touch. This is his x-ray. So approximately 3 years ago, he had a debridement of his fifth metatarsal bone, secondary to osteomyelitis. But the problem with that was because this has been deformed, there was pressure transfer to the submetatarsal 4 level. And this is exactly where he had the ulcer. So this is just showing the sequence of events in the wound care center from February 2021 to September 2021. And this is before I started working in the wound care center. And this is when I started seeing him in the wound care center. So this is pre-debridement pictures. This is post-debridement pictures. And then on December 15, 2021, I discussed possibly performing surgical intervention to help offload this ulcer since it's a recurrent thing. And he said, this ulcer has pretty much taken 2 years away of his life. So what I went ahead and did on December 21st was I did an osteotomy of the fourth metatarsal using a drill. Essentially, that just means making a cut in the bone of the fourth metatarsal, and no hardware is involved. You just let the distal aspect of the fourth metatarsal float, and that's the way the bone is going to heal. In addition to this, I also lengthened his Achilles tendon to decrease some of the forefoot loading. So this is his post-op x-rays demonstrating the osteotomy to the fourth metatarsal. So essentially you can see that this is just going to sublux dorsally, thereby offloading the ulcer. And then this is his first post-op visit, January 19th. The ulcer here was essentially healed. This is just a scab. And this is the final picture. This was a week ago. Like, you can't even tell that there was an ulcer there. His skin has completely remodeled. So he's pretty happy. He feels like he's gained his life back. Until this day, he's very appreciative of the procedure. Okay, case number 2. This was a pretty interesting case. A 62-year-old male, lifelong smoker. Saw him in the hospital. I was consulted regarding a left foot gas gangrene. He initially had a 5th-ray amputation and I&D by a previous podiatrist, but this podiatrist unfortunately did not promptly consult vascular service after seeing that his wounds were getting necrotic. This is his past medical history: insulin-dependent type 2 diabetes, diabetic neuropathy, peripheral vascular disease, and physical exam, he had non-palpable pulses on the left foot. However, they were biphasic signals obtained. He had a severely malodorous left foot, and his wound cultures obtained in the ER was positive for E. faecalis. So this is his x-ray, and this is what the previous podiatrist had done. And what the patient told me was the podiatrist first took off his 5th digit and then waited. And then when he failed to heal, he then proceeded to go further up to debride the wound. And it was approximately 2 weeks after finding out that the wound wasn't healing properly, he decided to refer the patient to vascular service. And this was his x-rays taken in the in the ER. You can appreciate some soft tissue emphysema over here and here, which is not a good sign. It means there's severe infection in the foot. Vascular was consulted, and the angiogram revealed stenosis in the popliteal artery, as well as occlusion of the anterior tibial artery. So intervention consisted of left SFA and popliteal angioplasty. So I waited a couple of days after the procedure, took him to the OR and did an open partial foot amputation just to decompress the infection. And I had to fillet his foot up because he had a lot of necrosis here, a lot of pus coming out. And then I waited two days after, took him back to the OR, and then did a more definitive amputation, which is a Chopard amputation. And I closed the defect. So this is his post-op x-ray. This is all that was left of his foot. And he was discharged in 6 weeks with 6 weeks of vancomycin and zosine managed by the infectious disease team. This slide is his most recent visit with me, which was last week. And as you can see, his stump has completely healed. He's ambulatory. He's walking with this custom prosthesis, which is enabling him to move around, and he's quite happy. Case 3, this is a 74-year-old female presented to the hospital due to incessant pain in her left foot. And also she came because of a mechanical fall. So past medical history was insulin-dependent type 2 diabetes, diabetic neuropathy, history of MRSA, morbid obesity, CAD, depression, hypertension. She's a non-smoker. Her white count taken in the ER was 23.2, and A1C is 8.3. Her wound cultures obtained from the right foot was positive for Proteus mirabilis, E. avium. Physical exam, she had non-palpable pulses to the foot. It was edematous, it was erythematous. There was also an area of fluctuance on the dorsolateral aspect of the foot, and the entire foot was just very painful to touch. So this is her x-rays taken in the ER. You can appreciate some soft tissue emphysema here, as well as on the lateral aspect of the foot where the fluctuant is, and this is where the fluctuant area is located. So I took her to the operating room the next day, and on opening her up, this was just necrotic tissue. She had a lot of pus also at about this level. So I left this open to drain out, and on the next day, this is what had transpired. She pretty much had further necrosis of the internal structures. And this is where I discussed with her, I wasn't very optimistic of limb salvage at the point. And I did recommend a below-knee amputation, but the patient vehemently denied. She refused a BKA, essentially. So I had a vascular service consulted, and an arteriogram was performed, and it showed these findings: patent SFA, some stenosis in the mid portion of it, occluded AT, and an enlarged peroneal, and also an occluded PT that was, the occlusion was distal to the origin of the PT. So the plan for the vascular service was they were going to do intervention if really they didn't want to do anything because they felt the foot was non-salvageable. So I took her back to the OR about 3 days later, did a more extensive debridement, and I had to take her entire 5th metatarsal, 5th digit off because it was completely dead at the time. And then took her back the next day, and I found out the 4th ray. So the 4th ray is this. The fourth ray was showing some evidence of necrosis in the bone. So I had to do a fourth ray amputation as well. And I had to do an incision over here to express some of the purulence from the heel. So this is the final post-op x-rays. To me, this is a pretty non-functional foot, but the patient was happy as long as part of her foot was kept intact. I think it's more of a psychological thing, really. So this is, you know, the sequence of pictures in the wound care center once the patient was discharged from March 2nd to June 29. I was treating her with serial debridements and negative pressure wound vac therapy. And it seems like she was responding to it because you can see the transition from this size of a defect to this. And then this is last pictures from October 5th. She's pretty much healed with the exception of this small partial thickness wound. Once this is healed, she's coming back to see me in 2 weeks. Once this is healed, she'll be fitted for prosthesis, but only time will tell whether she's gonna do well with the prosthesis. All right, case 4. This is a pleasant guy who came in. He was admitted in the hospital for a septic first metatarsophalangeal joint. My partner at the time had did a debridement of the joint and a washout, and then he sent the patient to me in the wound care center for follow-up care. And this is the resultant wound from the washout of the septic joint. This is from June 22nd to July 27th. And because this wound hadn't made any improvement at all, in a month of seeing him, I discussed, you know, doing a surgical procedure whereby I'll kind of alter the biomechanics of his foot such that he'll be putting less pressure where this ulcer is located. This ulcer is located on the bottom of his big toe joint. So the procedure I did was a Jones Teno suspension. What that essentially means is this is the extensor hallucis longus tendon, and it typically inserts at the base of your big toe joint. So the procedure involves transecting the tendon at the base of your big toe joint and then routing it through the head of your first metatarsal bone so that when you're walking, this tendon then pulls the first metatarsal head up, and that will offload the ulcer on the bottom of the big toe joint. In addition to doing this procedure, you have to fuse the small joint of the great toe joint so you have a stable lever arm when you're ambulating. So this is the immediate post-op x-rays of that patient. I'm not sure if you can see. So this is a drill hole in the first metatarsal through which I routed the extensor hallucis longus tendon through and then sutured the tendon upon itself and then fused the big toe joint. This is his post-op x-rays. This is day 2 of his post-op x-ray. This is a big old incision that was required, and his ulcer to some degree has improved. And this is on October 12th. It has markedly improved. The patient has been weight bearing since the onset of the procedure, and he's pretty happy. I'll see him again in a couple weeks, and hopefully this will be healed. The last case, this is Charcot deformity, which is often seen in patients with long-standing uncontrolled diabetes in the setting of neuropathy. What it does is Charcot causes an increase in osteoclastic activity in the bones, which causes it to break down and eventually cause deformity. So this is what the patient had. And when he came to the hospital for admission secondary to an infected ulcer, this is how it clinically looked. And if you can look on the x-ray, because of the Charcot deformity, what it does is it causes a collapsed rocker bottom type of foot due to a bony prominence here, making the patient have a higher chance of developing a wound where the collapsed bone is. And that's exactly what he had here. So what I did was I just did an extensive debridement of the wound, closed it up, and then kept him non-weight bearing for 3 weeks until the incision had healed. And once the incision was healed, he underwent serial total contact casting. And what this total contact cast does is transfer the weight from your foot to the anterior aspect of your leg, thereby taking some of the weight off your foot. So for the past 3 months, he's been undergoing this serial total contact cast, which is changed weekly. And despite the deformity in his foot, the wound has stayed healed. This is just the scar from the incision. So all in all, diabetes is a very debilitating disease to manage. And if patients are not aware of the complications that arise, then they start having issues. So this is a classification system I utilize to closely monitor my diabetic patients depending on what comorbidities they have. So for example, for risk groups of 0, they have no loss of protective sensation or no vascular disease. I can then just schedule them for annual follow-up. But then for risk group 1, if there's loss of protective sensation and or deformity, such as, whether it's a Charcot deformity or hammer toe deformity, I see them every 3 to 6 months. And if there's peripheral artery disease and or loss of protective sensation, I see them 2 to 3 months. But if there's a history of ulcer or a history of amputation, I see them in 1 to 2 months. All in all, managing diabetes is a multidisciplinary approach. Patients have to be aware of the complications that may arise from diabetes. And it involves close collaboration between the specialist, the primary care physician, and the vascular surgeon as well. All right, that's the end of my slide. Thank you for listening. Do you have any questions, anybody?
Any questions for Dr. Ezike? No? Dr. Ezike, one of the things I would say is for the audience, when you have below knee amputation, the reason why we talk about limb preservation when possible is you have about 40% more energy level expended when you have a below the knee amputation. When you have above, you're looking at 60%. That's a lot of work that they have to put into to ambulate. So the less, the better. If you have to amputate, the less, the better. Obviously, sometimes you have a non-functional foot, and you have the patient who just don't want anything removed. They just want to have the dead foot. So you have to deal with that. So, appreciate your work, and we hope to see you soon. Thank you, Dr. Ezike.
Thank you.
All right, we'll move right along, so we'll catch up. We have a couple more speakers, and I think we should be wrapping up soon. Our next speaker, if you have her available, is Dr. Monique Oye, relations.
Dr. Oye, it's going to be Dr. Sharon Beth Larson next, and then Dr. Monique Oye. Yeah.
Sounds good. Okay, our next speaker will be Dr. Sharon Beth Larson. She is a consultant cardiothoracic surgeon and professor of surgery at University of Iowa. And she will be talking to us today on the management of heart failure with LVAD or any other topic she may like. Thank you very much and welcome to Lagos.
Good morning. Thank you very much. It is my great honor to be included in this incredible meeting. I will get the slides shared here. Are you able to see the slides, Dr. Oye?
Yes.
Excellent, thank you. Yes, it is my honor to present on management of heart failure with left ventricular assist devices and also to discuss strategies and outcomes for explanting these assist devices in the recovered heart. I am an associate professor of surgery and cardiothoracic surgery at the University of Iowa. And I have no disclosures. And we'll talk about multiple surgical considerations at the time of left ventricular assist device implant in preparation for potential explant at the time of recovery, talk about the advantages of different surgical approaches, and provide examples of ventriculostomy closure strategies, and to understand the outcomes with left ventricular recovery and eventual explant of a left ventricular assist device. Now, when it comes to heart failure therapy, we know that optimization with goal-directed medical therapy for patients with heart failure improves their survival and also decreases hospitalization. Nonetheless, 5% of those patients with heart failure will progress to develop advanced heart failure. And we know that from the REMATCH trial, left ventricular assist device therapy actually improves survival in stage D heart failure. Traditionally, left ventricular assist devices are used as destination therapy, meaning we're going to place this pump and the patient is going to live the rest of their life with this assist device for their failing heart. Other patients, left ventricular assist devices are used as a bridge to transplant. So the pump takes over for the failing heart until an appropriate donor match can be made for heart transplantation. But as we see improvements in our technology with assist devices and enhanced clinical outcomes utilizing these assist devices, the longer patients are surviving with these devices, we're actually seeing evidence of myocardial recovery during therapy with left ventricular assist devices. So it's showing evidence of reversibility of the myocardial dysfunction for which the LVAD was placed in the originally. But we know that the rates of myocardial recovery are very low and only approaches just above 1%. But when we do consider those very few cases of left ventricular recovery, we do see reversal of the remodeling process. So we see regression or reversal of pathological hypertrophy, distortion of the chamber shape, and changes in the myocardial dysfunction. It's important then, if we're shooting for recovery and explant of these devices, that we correct any reversible pathophysiological processes. So we want to aggressively seek treatment for ischemia of the failing heart, remove any cardiotoxic agents, treat any arrhythmias, make sure we're appropriately managing any concomitant thyroid disease, and obviously making sure the patients are ceasing any alcohol usage leading to any dilated cardiomyopathy. And with recovery, we want to make sure we're appropriately unloading that LV as well. When we see improvement in left ventricular end systolic and end diastolic dimensions, diastolic parameters, and decreased left ventricular masses, we know that we're on the right track towards recovery and explant. That left ventricular assist device unloading actually leads to a decrease in circulating levels of many neurohormones. And there can also be electrical remodeling reflected by shortening of the QRS and QTC intervals after left ventricular assist device placement. And these are all associated with an increase in left ventricular ejection fraction and a decrease in filling pressures. When we see evidence of recovery, we want to have some kind of quantitative measurement for determining the appropriate timing of LVAD explant. So we know that recovery is defined as an ejection fraction which has now reached over 40%, and end diastolic dimensions which are going to be smaller than 6 centimeters. Other independent predictors of recovery would be age less than 50 years, etiology of non-ischemic cardiomyopathies, time from cardiac diagnosis less than 2 years, so not someone who's not going to have really long-standing chronic heart failure. The absence of need for an implantable cardioverter defibrillator, a creatinine level that's less than 1.2, and again, that end diastolic dimension less than 6.5 centimeters. Other recovery assessment tools include the ICAR score, which is a weighted score that was specifically developed to effectively stratify patients based on their probability of recovery, including all of those parameters. When we approach weaning of the left ventricular assist device, when adequately unloaded, patients are then serially evaluated at minimal pump speeds to check for normalization of aortic valve opening time. They're also selected for explant after demonstrating preserved left ventricular size with the reduced flows on the LVAD and function and no rise in filling pressures during that weaning process. Now, INTERMACS, our registry, which we report all of our heart failure patients to, reported a 1-year survival after we explant that LVAD. at 86%. So this is a fairly successful model for a recovered heart when we consider that the only options before were heart transplantation or continuing to live the rest of your days with this LVAD. As we're planning for the explant of a left ventricular assist device in a bridge to recovery scenario, surgical considerations will actually begin at the time when we first place that LVAD. So this will include addressing concomitant valvular issues and in subsequent interventions at the time of implanting the LVAD for the traditional bridge to transplant or destination settings. So those patients who may have tricuspid regurgitation, we would want to address that with a ring annuloplasty, for example, at the time of their LVAD implant. Overall, optimizing function of the recovered heart at the time of explant necessitates correction of valvular heart dysfunction at the time of implant for LVADs, so that the heart can work at its most optimal and the assist device can work at its most optimal and effectively promote reverse remodeling during that therapy. Other surgical conditions at the time of explant will include whether or not we want to do this with a supportive cardiopulmonary bypass without arrest, whether there's any evidence of left ventricular thrombus at the time of explant, which we'd also want to evacuate, and then any enduring structural heart issues that would ultimately negatively impact the overall function of the recovered myocardium. When we consider our surgical approach, there's a reduced sternotomy for explant of the LVAD versus minimally invasive approaches. And a lot of that approach at the time of explant depends on how the approach was made at the time of implant. And we know with reduced sternotomy, there's an increased risk of blood transfusion requirements, increased blood transfusion, increased volume stress on the recovered heart is not ideal. Injury to the heart that may threaten the success of the LVAD explant of a recovered heart. So we know that at the time of LVAD implant and as a patient heals, there's going to be a significant amount of adhesions that form. And as we take down those adhesions, how might that damage the recovered myocardium? With minimally invasive approaches, we have to also consider repair of the left ventricular apex, which commonly will use a femoral and outflow graft arterial access and femoral venous access for cardiopulmonary bypass without needing to arrest the heart. When we place the LVAD, we make a large left ventriculostomy, and so we need to close that and ultimately transect the outflow graft of our LVAD. So in order to close the left ventriculostomy, we need to fashion an apical plug. This is a plug fashioned from surgical felt with or without a biologic cap or covering. That plug is then positioned within the original sewing ring and secured, eliminating the need for an extensive LV repair. Other surgeons have approached closure of the left ventriculostomy with a patch. Others approach it with a primary closure. So that's physically approximating the muscular edges of the left ventricle, similar to left ventricular aneurysm repair, with a series of interrupted sutures or with a running suture line. And then the edges of the sewing ring can actually provide a buttress for that suture line as well. And then the outflow graft of the left ventricular assist device is transected at its insertion point on the ascending aorta, and that can either be done by oversewing it or with a surgical stapler. When we wish to approach the explant of an LVAD with a minimally invasive technique, this will involve complete removal of the flow graft complex, but sometimes that's not altogether possible in a minimally invasive technique. So retention of portions or of the entire pump with the inflow and outflow graft is necessary, which is approaching more of a decommissioning of the LVAD rather than explant. Multiple smaller incisions overlying some of those key components of the LVAD may be made to access the actual pump itself, the inflow sites at the apex of the left ventricle, and the outflow cannula in the ascending aorta. The outflow graft can be used for arterial access for cardiopulmonary bypass. So this is the graft that's going to naturally carry that assisted blood flow to the rest of the body. And that graft then can be oversewn or stapled, as mentioned previously, but it will leave a small retained portion of the outflow graft on the ascending aorta after it's stapled. Now, with the most minimally invasive technique, this completely avoids cardiopulmonary bypass. You leave the entire left ventricular assist device intracorporeally and only cut the drive line or the power source leading to the device. And again, this is what we would consider decommissioning rather than an explant of the LVAD. You do risk having pump thrombus that's contained. And rare complications would involve infection of the residual graft material that's left in place for the outflow graft and some thromboembolic incidents. So when we're considering explant of an LVAD in the recovered heart, what is the sustainability of this? Well, device explant can be achieved in up to 73% of very carefully selected patients with a combination of maximal goal-directed medical therapy and clenbuterol. Now, 36% of patients that had an explant ended up having sustainable remission from heart failure recurrence, meaning their recovered myocardium continued to have that ejection fraction well over 40%, and their end diastolic dimensions did not exceed 6 centimeters. And monitoring with echocardiograms immediately postoperatively daily, then stretching it out to every 6 months to monitor for the sustained recovery of the myocardium. And frequent blood work, including pro-BNP levels and BNP plasma levels to check for any signs of recurrence of heart failure. Now, long-term, the risk of recurrent heart failure is highest in the first year post-explant, but really tapers off over time. So if you're appropriately choosing these patients, having a successful explant surgery, then the likelihood of them surviving long-term without recurrence of heart failure is quite high. So long-term survival free from LVAD, transplant, or death after an explant is 90% at 1 year and 77% at 3 years. These are much better outcomes than some of our transplant populations. Immediately after discontinuation of the LVAD support, we do see that the ejection fraction can decrease from anywhere from 7 to 40%, and that the dimensions can increase from 0.4 to 5.2 centimeters. After 3 years, we see ejection fractions of 42% and dimensions of 5.8 centimeters. Post-explant, heart failure recurrence is related to the duration of heart failure before VAD implantation. And this is why one of the predictors of success is the length of diagnosis of heart failure prior to the LVAD implant. And pre-implant history of heart failure greater than 5 years is really the most relevant risk factor for post-weaning heart failure recurrence. So again, if your diagnosis of heart failure exceeds 5 years prior to your original LVAD implant, the likelihood of recovery and successful or sustained recovery after explant is going to be minimal. So thank you very much. It's an honor to get to present some of the work we're doing here at the University of Iowa. It's been great to partner with Dr. Oye, and such an honor to be part of this very important conference. Thank you so very much.
Thank you, Dr. Lobster. Any questions for Dr. Lobster? Dr. Stenosis has a question for you.
Yes.
Cardiothoracic surgeon here in Lagos, trained in the US, and he's here with questions.
Thank you very much, Dr. Lobster. An eye-opener. I still have a question for you. When would you absolutely have to go to transplant now? When what percentage of your patients that have a failed heart failure would you recommended LVAD for, and what are the absolute indications for transplant now?
Yes. Dr. Oye, so I'm not sure if we're the distance from microphone. I just want to make.
Yeah, he'll come closer to you. Right.
Yeah. Thanks for the talk, Dr. Larson. That was awesome. What are the absolute indications for transplant now with the LVAD way? As when would you when would you go to transplant, and about when it would be a bridge transplant therapy?
That's a great question, and one that we're actively being faced with right now, and especially after the heart allocation recently faced in the United States. So where we found that prior to the heart allocation system change, there were a far greater number of patients being placed on an LVAD as destination or bridge to transplant therapy versus going directly to heart transplantation. What we see after the heart allocation system changes, and that meant that someone who was stable on an LVAD used to be at the highest indication for a heart transplantation. After our heart allocation system changes, they drop down to a much lower level, and so had a much lower priority for getting a heart transplant if they were stable on a left ventricular assist device. We find that to be true because the outcomes on an LVAD are reaching that of a heart transplantation. So the patients are doing as well with an LVAD as they would be with a heart transplant. What that means is that for patients who would be going, or you would wish to go directly for heart transplantation, and many of those patients are going to be those that also have associated right ventricular dysfunction that would not be successful with an LVAD, because we know we have to have appropriate right ventricular function in order for the LVAD to function appropriately as well. So in the severe biventricular failure patient, we would want to proceed directly to heart transplantation, supporting them with a temporary device like an Impella, temporary LVAD, with a balloon pump, although we don't achieve as good of an improvement in our cardiac index with the balloon as we do our Impella. For a patient with an LVAD, many of those patients these days would be those that would be inappropriate for heart transplantation. So those patients who are aging out of a heart transplant, and those who perhaps had a level of non-compliance that would not be compatible with giving them such a precious limited resource as a donor heart.
Yeah, Dr. Stenosis has one more question.
Yeah, thank you. And one more question, please. So the different LVADs available to you in your experience, say someone was to get an LVAD in sub-Saharan Africa, for example, what is there a particular type of LVAD you would recommend, or that easier to manage?
Yes, well, currently we really only have one durable implantable left ventricular assist device approved in the United States. So then my recommendation in sub-Saharan Africa would be the same that I would make here in Iowa City, Iowa. And that's with the HeartMate 3 device. It's an Abbott device. And that is a later generation model of the HeartMate 2 pump, also from Abbott. And we did have what was called a HeartWare device, which very much resembled the HeartMate 3, an implantable durable device. But that was taken off of the market due to the much higher rate of thromboembolic events and strokes. So we only really have one approved device to use for our left ventricular assist device implants, and that is the HeartMate 3.
Thank you. Thank you, Dr. Larson. I'll certainly talk with Dr. Sanusi, and maybe will reach out to you and see the feasibility of doing the LVAD in this environment. So we'll have that discussion go. Thank you very much, and I hope to see you in Chicago next year.
Thank you very much. My pleasure, and have a wonderful rest of your meeting.
Thank you. Very good. Well, that was pretty interesting and different from what we see here. So hopefully we can put you in contact with Dr. Larson and see how things work out. Our next speaker was coming to us from Detroit, Michigan. She completed her undergraduate educational training at the West Virginia College and proceeded to do an internal medicine residency at the University of Florida, and then now proceeded to do and is doing her cardiology fellowship at the Henry Ford Institution in Detroit. Her name is Monique Oye, my daughter. Thank you.
Hi, everyone. I'm just trying to see how I can share my screen. Do you see my PowerPoint?
Yes, we do.
Yes, we can.
Okay. Okay, so we'll get started. My name is Monique Oye. I'm a cardiology fellow at Henry Ford Hospital in Detroit, Michigan. And today I'm going to be talking about spontaneous coronary artery dissection. I'm going to start out with a case presentation of a case that we saw here at our hospital earlier this year, and then go further into this disease process and how we manage it. So the outline will go start with the case, talk about the pathophysiology, the diagnosis and management of this disease. So our patient was a 34-year-old female. She had no past medical history and presented to our hospital with severe substernal chest pain after a recent argument with a family member. She went into the ED and her electrocardiogram showed significant ST elevations in lead 1 and AVL. She was taken emergently to the cardiac cath lab, and her coronary angiogram showed complete occlusion of the left main coronary artery, suspected to be due to spontaneous coronary artery dissection, also known as SCAD. In the cath lab, attempts for percutaneous coronary intervention, or PCI, to the prox left main and mid LAD were performed with drug-eluting stent, and then a second stent had to be placed more distal into the left anterior descending artery. During the case, she experienced ventricular fibrillation arrest, requiring defibrillation ×1, as well as, since she was presenting at this point in cardiogenic shock with arrest and hemodynamically unstable, an Impella was placed, similar to what Dr. Larson was just talking about, which is a temporary ventricular assist device that we place in patients with cardiogenic shock, as well as VA ECMO was also placed. In her left femoral vein, she had a 24 French sheath and a 17 French outflow sheath into the femoral artery with a 6 French reperfusion catheter to make sure that she didn't lose distal pulses with having these large bore sheaths in her peripheral arteries for her additional support to stabilize her in the meantime. So this is her EKG when she came in. We can see here circled are the ST elevations in leads 1 and AVL. And her coronary angiogram, because the EKG was concerning that it was likely one of the left-sided coronary arteries that were affected, they shot the right coronary artery first because we did not think it would be involved. And we can see the right coronary artery is normal, good flow throughout the vessel, no signs of disease. So then when they went to shoot the left side, this first image we see, the catheter is going into left main coronary artery, and there is absolutely no flow going down into that vessel. We should see that vessel opening up and perfusing that anterior portion of the heart, but it's essentially a stub here, nothing flowing past this left main coronary artery. After about 4 hours in the case, this is the final result where we see the vessel was opened up and we now have flow. There's an Impella sitting here in the left ventricle for support. And with the Impella, it essentially sits in the left ventricle. It has an inlet where blood is pulled into the inlet and able to be pushed into an outlet and through the ascending aorta and deliver blood to the rest of the body. However, in this image, although we have flow, her ischemic time was very long. So if we look at the heart, it's barely pumping at this time, barely squeezing. She's barely getting any cardiac output. So while she was in the cath lab, because she is so critically ill at this time, cardiothoracic surgery was consulted while she was on the table to see if CABG would be an acceptable option for her. The CT surgeon reviewed her case and her films. He noted that the angiogram shows that the left ventricle is barely moving, her right ventricle looks okay, and her right coronary artery was normal. They noted that the left system appears open now that she's been stented, but given her prolonged ischemic time without any collaterals and the left main being shut down, essentially not getting any perfusion to the left side of the heart, she received a very significant insult that she may not recover from. The plan was to maximize her on support with the VA ECMO and Impella and evaluate the patient for potential heart transplants at this time. So her echocardiogram here shows, this is the left ventricle where we see it's barely moving. They estimated her ejection fraction to be about 15 to 20% at this time. And like I said, this was previously a healthy young lady who had no comorbidities prior to this presentation, now with severe heart failure requiring potentially a new heart. So 4 days after her initial presentation to the ED, she gets a heart transplant. Because she was so sick, requiring VA ECMO, she was bumped to the top of the transplant list, status 1. So she's a perfect candidate for a heart transplant, kind of going off that last talk. She's not someone we want to put an LVAD in because she's young. She doesn't have any other risk factors to prevent heart transplant not being a good option for her. During the heart transplant procedure with the cardiothoracic surgeons, vascular surgery was also consulted in that surgery, and they decannulated the right ECMO cannula. They repaired the right common femoral artery, the right common femoral vein, and superficial femoral arteries, as well as repair of the left common femoral artery and left superficial femoral artery. Because she did have these large cannulas, while she was in the ICU, started to develop diminished flow in her lower extremities. 26 days after she received her heart, she was discharged home. She continues to have chronic leg pain from when she was in the ICU with the peripheral ECMO. And she recently followed up with vascular surgery outpatient because she's been complaining of leg pain. She's unable to do her previous activities like walking, running without having leg pain. The vascular surgeon did note that they think it's probably from relative ischemia to her legs while she was in the ICU. They got ABIs, which show decreased perfusion in the left lower extremity, likely from her arterial repairs. But at this point, they recommend just watchful waiting. They don't believe there's much to do, and they'll just reevaluate her symptoms in about 6 months. She's also been screened for fibromuscular dysplasia. As we'll talk about, this can be a risk factor for developing spontaneous coronary artery dissection. The screening was negative for her. And she continues to follow closely with the advanced heart failure specialist post-transplant. So this patient is an extreme case of spontaneous coronary artery dissection, something we never want to see. But at the end of the day, she was able to have a good outcome because she was in an institution that was able to provide her with temporary cardiopulmonary support with ECMO and eventual heart transplant. And a lot of facilities, not in major cities, this patient may have died because they would not have had those resources available. So now I'm just going to go into this disease process and talk about how we diagnose and manage these patients. So SCAD, spontaneous coronary artery dissection, it's an acute coronary event defined by separation of the coronary artery wall that is not iatrogenic and not related to trauma. These patients are, over 90% are going to be women who present with SCAD, and the mean presentation is going to be around 40s to 50s. These are not going to be our traditional cardiovascular patients with those risk factors such as hypertension, hyperlipidemia, diabetes, tobacco use. These are going to be our healthy young females who are coming in with essentially acute coronary syndrome. Some studies show that the prevalence of SCAD is about 4% in all patients presenting with ACS, and about 35% in women 50 years or younger presenting with ACS. The risk factors for this entity are going to be patients who have fibromuscular dysplasia, connective tissue disorders, genetic mutations such as Marfan syndrome, patients undergoing extreme emotional stress, this can be a trigger, extreme exercise, pregnancy, or hormonal therapy. Our patient, prior to her presenting, was noted to have been in an intense argument with a family member, and it was noted that maybe this was her trigger for why she developed SCAD. So pregnancy-associated SCAD is going to be an important subset of patients, and this can occur anytime during the pregnancy or postpartum, with most cases occurring postpartum. SCAD-associated pregnancy is going to be more severe clinical presentation, including the left main, multi-vessels involved, or cardiogenic shock. In terms of the prevalence, it remains uncertain, probably because it's underdiagnosed. As I said, these patients are going to be young, female, not traditional risk factors. So, and many times, unless you have a good clinician who's actually thinking about SCAD, they may not diagnose this, as well as limitations with angiographic techniques. A lot of times it's useful to use intravascular ultrasound IVUS to help diagnose this. In terms of the pathophysiology, so the normal anatomy of the coronary artery, we have the tunica intima, which is the inner layer that's in contact with the lumen, and it's separated from the tunica media by an internal elastic lamina. We have the tunica media, which is the middle layer, and it's comprised of smooth muscle cells, helps regulate the vascular tone, and the adventitia that surrounds the media through fibrous connective tissue and provides support for the epicardial vessel. With SCAD, we have a hematoma that forms within that tunica media, separating the intima or the intima media from the vessel, and it ends up compressing that true lumen, leading to ischemia. And there's several hypotheses of how this occurs. One is that potentially a flap develops first, and then the blood enters into the intimal space from the true lumen via this flap. And the other hypothesis is that we have a hematoma that forms within the tunica media first, and causes disruption and compresses and occludes the true lumen as the hematoma expands. On angiogram, there's different types that we can see. Type 1 SCAD is we're going to see contrast staining of the false lumen. Type 2 is going to be long, diffuse, and smooth narrowing of the vessel. Type 3 is going to be a focal or tubular stenosis, which can mimic atherosclerotic disease. So in patients that present like this, IVUS would be good to look at that vessel better. And type 4 will be complete vessel occlusion. In terms of management, so we're not going to manage these patients the same as those patients who present with atherosclerotic acute coronary syndrome. In these patients, we want to be conservative as possible. So diagnostic left heart catheterization is going to be the gold standard to diagnose the condition. But in terms of PCI and SCAD, this is going to be less predictable. And unless the patient is presenting similar to how our patient presented with acute cardiogenic shock, hemodynamic instability, we actually want to manage these patients conservatively because these vessels are fragile. And if we go in and put instrumentations, wire, stents, we can actually propagate the dissection proximal and distal to that stent, and then they may require even longer stents after propagating the dissection. So the main thing of management of these patients, if you can be conservative, you want to be. CABG can be considered if PCI has failed or patients have high-risk lesions, but once again, these vessels are fragile, so this can be challenging. And the sutures may not hold, they may be more prone to complications. And these patients, once their native coronaries heal, because normally in about 4 to 6 weeks, these will heal on their own. So if we go in and put a bypass graft, once that normal coronary artery heals, that bypass graft is likely going to fail due to competitive flow in the native system. However, if the patient's hemodynamically is stable and it's the only option to save their life, CABG can be an effective measure. So as I said, we want to treat conservatively. About 95% of these patients are going to heal within 30 days. So if we don't have ongoing ischemia, if there's no hemodynamic instability, try to avoid doing any invasive procedures. In terms of medications, if they have signs of left ventricular dysfunction, their ejection fraction's down, we should start medical therapy for heart failure. If they do get PCI, they need to be on dual antiplatelet therapy, aspirin Plavix. In patients that do not receive PCI, the evidence on whether we should use dual antiplatelet therapy is not as clear, but typically we'll treat them about 1 to 3 months with DAPT for medical management of ACS, and then eventually drop the Plavix and do aspirin indefinitely. So just a diagram summarizing this. So if they don't have high-risk features, treat them conservatively. You can diagnose them with the coronary angiogram, but try not to do any PCI or invasive procedures. Monitor them in the hospital for an extended amount of time, about 3 to 5 days, to make sure that they remain stable. Start them on aspirin indefinitely, start Plavix for at least 1 month, and medications if they have left ventricular dysfunction. Long-term management, they should be following up with vascular medicine, screening for fibromuscular dysplasia, other genetic disorders that may have caused this, follow up with cardiology for reoccurrence, and symptom-guided imaging, as well as cardiac rehabilitation to get them back into their baseline function. If they're high risk, multivessel involved, cardiogenic shock, then we want to try to get them revascularized with either PCI or CABG. Long-term management, so it can be associated with fibromuscular dysplasia. So in about 50% of cases, they can have head and neck aneurysms. So these patients, once we diagnose them with SCAD, they should go under complete screening with either CT or MRA from head to pelvis to try to identify any additional extracoronary vascular abnormalities. Recurrence of SCAD is possible and has been reported up to 10 to 30% of patients. And we want to have secondary prevention, including avoidance of potential triggers, such as extreme stress, extreme exertion, and blood pressure control. If a patient has pregnancy-associated SCAD or SCAD in general, pregnancy should probably be discouraged, but if they do desire to get pregnant, they should receive adequate counseling. So in summary, key points, diagnosing SCAD requires a high index of suspicion. These are going to be young patients, typically female patients, who are presenting with acute coronary syndrome, and patients that you wouldn't typically think would have acute coronary syndrome. So if we see a patient presenting like this, we should always have SCAD in our differential. If we can manage them medically, if they're clinically stable, that's going to be our main goal. But if they have a high-risk presentation, revascularization is going to be recommended. Long-term management includes screening for fibromuscular dysplasia, other genetic disorders, and monitoring for reoccurrence, as well as cardiac rehabilitation. And that's all I have. So thank you for your attention. And if you have any questions, I'll be happy to answer.
Thank you, Monique. Nice job. Any questions from the audience?
Thank you, Dr. Monique, for the educating lecture.
So again, rare.
But I want to say something. Given what you just said, that avoid instrumentation, and that about a percentage you mentioned that it will resolve spontaneously. A percentage of them will resolve spontaneously.
It's talking about resolution, spontaneous resolution in some patients. So you don't do initial aggressive therapy, conservative therapy initially. Mm-hmm. Yeah. How long do you watch the conservative managed patients? How do you follow up?
So typically, if you manage them conservatively in about 4 to 6 weeks, then bring them back and do another diagnostic coronary angiogram to see if that vessel has resolved. And in the meantime, you just manage them medically.
Most importantly, on young patients, avoid triggers like stress, screaming. So that person sue the family for. Thank you, Monique. Appreciate it.
All right.
so we'll get on to our next speaker. Next speaker is coming to us from Berkeley, West Virginia. It's Caitlin Boyd. She is a fourth-year medical student. Will give us case presentation while we proceed to her. We'll conclude with having a good time. We'll conclude one more talk after that, and we'll call it a day. It's been a long day, so we'll get it done. After that, we'll do the stroke case. Okay. Are you ready?
I'm ready. Hello, everybody. My name is Caitlin Boyd, and like Dr. Oye said, I'm a fourth-year medical student here in Beckley, West Virginia. I'll be presenting on the management of subclavian artery stenosis with angioplasty. So these are just some of the objectives of the talk. We're going to discuss the subclavian artery stenosis and review the significance of the case reports presented. I'm going to present the cases of subclavian artery stenosis and compare it to currently available literature, drawing conclusions about risk factors, causality, and how the cases could have been managed compared to literary evidence, and discuss the causes, signs and symptoms, diagnosis, and treatment of subclavian artery stenosis in relation to the cases presented. So to begin, we're going to discuss the subclavian artery stenosis in general. So the left subclavian artery is 4 times more likely to be affected than the right or innominate arteries. Due to the degree of potential collateralization and isolated stenosis, the likelihood of symptoms is less than in other vascular beds. Once obstructive disease affects other aortic arch vessels, such as the carotid or vertebral arteries, the likelihood of steal or ischemic symptoms drastically increases. Upper extremity symptoms include claudication, muscle fatigue, rest pain, and finger necrosis from embolic debris. Neurologic issues due to vertebrobasilar hypoperfusion include visual disturbances, syncope, ataxia, vertigo, dysphagia, dysarthria, and facial sensory deficits. In patients with internal mammary artery grafts as a result of cabbage surgery, the symptoms of ischemic heart disease, including angina pectoris, due to coronary subclavian steal predominate. So the significance of these case reports: subclavian artery stenosis can lead to significant morbidity due to symptomatic ischemic issues affecting the upper extremities, brain, and even the heart. Of those patients having subclavian or innominate lesions, 50% have concomitant CAD, 27% have lower extremity artery involvement, and 29% have carotid obstructive disease. As a result, patients affected are at increased risk of developing symptomatic CAD and cerebrovascular events. The incidence in the general population is 3 to 4%, but it can be as high as 11 to 18% in patients with documented peripheral artery disease. So for the first case, the patient was a 68-year-old female who presented to the clinic with the chief complaint of hypertension. This hypertension began in May of 2022. The patient also complained of pain to the left side of her neck and denied trauma to that area. She returned 12 days later to the office for a follow-up regarding her CT scan results. She stated that she was in pain and that her left hand hurt. She showed no signs of fever or chills at that time. Her past medical history was significant for hypertension, hypercholesterolemia, peripheral vascular disease, and atherosclerosis. Her past surgical history was significant for left iliac artery surgery and stent placement, and arteriogram with atherectomy/angioplasty of her right proximal SFA and angioplasty of left CFA. CT angio of her upper extremity with IV contrast showed calcified plaque at the origin of the left subclavian artery with significant stenosis. And CT angio of her neck with contrast showed occlusion of the right internal carotid artery. You can see that in the imaging there. Point of care, she had a strong brachial pulse on the right side, but weak on the left. The radial pulse is palpable on the right side, but weak on the left. She was sent for a CTA of the left vena cava runoff and carotids. She also had tenderness to the left side of the neck, but denied any trauma to that area. When she returned on the 12th, she had no left arm pain. Her CTA showed subclavian stenosis at the origin. She had weak radial and brachial pulses on both sides, but the right side did have stronger pulses. She was advised to undergo surgery at that time. So she underwent the left branchial approach for arteriogram, cannulation of proximal complete total occlusion of the subclavian artery, balloon angioplasty of the proximal occlusion of subclavian artery with a 5x20/18 and LP balloon. And we also did deployment of the 7x37mm express stent. So this kind of just describes the surgery in a little more detail. And this is the intraoperative imaging. So on the image on the left is pre-op. You can see stenosis there. And on the right was intraoperative. Oh, got flipped sideways somehow. And then here you can see the post-op imaging with the stent in place. It got flipped sideways. And then for the second case we're going to discuss, it was a 62-year-old female who presented for evaluation of stenosis in her left extremity. Her doctor had called and spoke with Dr. Oye about stenosis near a stent that Dr. Oye had previously placed in the subclavian artery. She had bilateral subclavian arteriogram on January 9th of 2017 with stenting in the left subclavian. She had not been to the office since then. She denied any pain. There was no tobacco use noted. There were no signs of fever or chills, and she had no further complaints or concerns at that time. Past medical history was significant for hypertension, hyperlipidemia, heart disease. Her past surgical history was significant for bilateral subclavian arteriogram with angiojet embolectomy and stent placement to the left back in 2017. And she had a left carotid endarterectomy in March of 2017 as well. So point of care, a stent was placed in the left subclavian in 2017, as I stated. She recently was at another hospital and a left subclavian stenosis was found near her previously placed stent. When examined, DP and PT were noted. Her left arm radial pulse was weak and her left arm brachial pulse was absent. She needed angioplasty and possible stenting of the left subclavian vein. So she was scheduled for surgery at that time. She underwent left brachial approach for left subclavian angioplasty and stenting. We used the 8x37mm express stent for her. And you can see here is pre-op. And this is post-op imaging with the stent in place. So what causes subclavian artery stenosis? It can be caused by atherosclerosis, which is the most common cause, arteritis, inflammation due to radiation exposure, compression syndromes, fibromuscular dysplasia, and neurofibromatosis. So for the diagnosis, on physical exam, you can find unequal arm blood pressures. A systolic cutoff pressure difference or gradient of more than 10 millimeters can be used to delineate hemodynamic significance and justify further investigation. You can also find absent or significantly diminished pulses in comparison to the contralateral arm. You can hear cervical or supraclavicular bruits. You can also see ischemic findings such as finger ulcers or gangrenous skin changes or nail bed splinter hemorrhages. Your exam should also focus on cerebral circulation. You should palpate the carotid pulses and also tape for vertebral and carotid bruits. Definitive diagnosis is through imaging. You can do duplex ultrasound with color flow, which is the non-invasive modality of choice. Findings suggestive of obstruction include waveform dampening or monophasic changes. Color aliasing suggestive of turbulent flow and increased blood flow velocities at the suspected sites of stenosis. Ultrasound can also detect reversal of ipsilateral vertebral artery flow, as seen in subclavian steal syndrome. This image here is a Doppler of proximal left subclavian lesion. Other more expensive and invasive tests include CTA and/or MRA. CTA provides